Good morning, good afternoon, and good evening. Welcome to the Health Systems for Health Security workshop. We are delighted to have Jawad Mahul open today's event with Professor Simone Botendijk. He is Assistant Director General of Emergency Preparedness and International Health Regulations at the WHO, and he will be officially kicking off today's event. Thank you very much.
Yeah, thank you very much for giving me the floor. Professor Simon Botendijk, thank you for co-organizing this important workshop with WHO. A representative and expert from member state, partners, agencies, academia, institutions, and students from universities around the world. Good morning, good afternoon, and good evening to all. And thank you very much for joining us for this very important topic. Recent and ongoing public health emergencies have been reminding us of how severe and large public health emergencies remain a major challenge to countries' health security and their health system worldwide. These have also been reminders of the economic and social impact that health emergencies can have. Estimated cost of recent and ongoing pandemics include loss of trillions of US dollars in productivity as well as a social impact. The current pandemic has also illustrated how threat to one country is a threat to all countries across the world. The world will not be safer unless that all countries are prepared to deal with the epidemic and pandemic. Despite efforts to strengthen national and global emergency preparedness in recent years, no country was fully prepared to deal with health emergency of such magnitude and scale as the COVID-19. A recent analysis of the International Health Regulation Self-Assessment Annual reporting data conducted in the context of the COVID-19 pandemic showed that countries vary very widely in their ability to prevent, detect, respond to, and recover from outbreaks. The implementation of the international health regulation remain an indispensable foundation for health emergency preparedness and response, which should be complemented with adequate public health infrastructure and capacities. As the WHO Director General, Dr. Tedros always reminded us, health security and universal health coverage are two sides of the same coin. During this pandemic, we have seen how limits in health system and public health infrastructures give rise to challenges in preparedness and management of health emergencies and vice versa. So, what capacity are required for resilient and responsive health system for health security? In March 2019, an expert group consultation discussed an early version of the Health System for Health Security framework. Since then, the framework has been reviewed by technical experts from WHO, member state, partner agencies, and academia, and I would like to thank all for their continued technical support in the finalization of the framework. Today, the world needs a sustainable and sustained political commitment at the highest level to break the cycle of pandemic and neglect that has characterized past response to pandemic and large-scale epidemics. Finally, I would like to express my appreciation to our academia partners from the University of Leeds for co-hosting this event and the collaborative partnership. I wish you all fruitful discussion and successful meeting as we strive towards strong health emergency preparedness and response system. Thank you, and back to you.
Thank you very much. I am now very pleased to present Professor Simone Botendijk, who is the Vice Chancellor of the University of Leeds. Simone, over to you.
Thank you, Garrett, and thank you, Dr. Mazur, for this great introduction. As I was preparing for today, I realized it feels a bit like full circle for me. My very first job when I graduated from medical school in the Netherlands quite a while ago was for WHO for half a year in the European office in Copenhagen, where my job was to bring together policymakers and university researchers and teachers around lots of topics having to do with perinatal health, which was my specialty area at the time. And already at that time, I had a really keen sense that what we needed to do in universities is work together and work together globally, because the issues are so huge. And that, of course, hasn't changed. And what we're talking about today is exactly that. And it feels like now being in a position of university leadership, being able to support people like Gerd Brown, colleagues from Nuffield and Polis and the whole University of Leeds community, to work together with WHO on figuring out ways to actually, in collaboration, deal with these huge global issues. It's wonderful, and I feel extremely honored. And the University of Leeds is very committed to this new cause. So really hoping we can work together, we can help you create a network of global universities, policymakers, country leaders. So next time we're better prepared, and not just in terms of COVID. I think many of the global challenges will require a very similar approach. So for me, this network can actually be a pilot, probably like a role model for how we need to deal with global issues that challenge all of us. So I think the scale of it is absolutely enormous, and this could be a real breakthrough in how we together tackle these immense issues. So the University of Leeds is embarking on a new strategy period, and the title of our strategy is Universal Values, Global Change. And for us, the value of collaboration versus competition probably is the most important one. And I'm sad to say that universities globally still compete far too much. We need to start collaborating as if our lives depend on it, because they actually do. And in terms of the global pandemic, of course, that's literally true. We have no time to waste. We can't be worried about our own position in global rankings or whether we're outsmarting colleague universities. We need to be much more collaborative everywhere. Between universities, within universities, none of these big issues can be solved by one university discipline. We need a multidisciplinary approach. We need to think about finance, the influence of poverty on health, culture, and how it all plays into whether we can actually beat these pandemics or not, and whether we can do it early enough that we don't have to spend trillions and we don't need to needlessly actually lose enormous numbers of lives. So we need to work together within universities, and that's what we'll start doing at the University of Leeds. And this center, of course, is a great example. We need to start working together between universities, but we also need to work together with governments, with industry, with everybody who should be engaged with trying to solve the global challenges. And I think one place that universities have in all of this, which is often not mentioned enough, is the fact that we're also training the next generation of global citizens. We're training the young people who are very focused on wanting to hit the ground running. They're literally asking us to be taught about global challenges, to be taught in multidisciplinary groups, to be taught across the piece about the influence of all these issues on each other. So we're also going to use the emerging collaboration around this theme to bring that straight into our classrooms. And the University of Leeds is also going to use the new digital and online technology that's emerging, that we're all embracing, that we're using to keep being connected in spite of all the problems with the pandemic and the travel restrictions. We're going to use that technology to bring our research to a global population at a scale and a quality that was previously unprecedented. So we're working together as a community to also think about how we can bring everything we're doing to the world. And that's one other reason why I'm so excited about the collaboration that we're now building with WHO, because we're going to use it not just in our own classrooms, but in global classrooms. Thank you so much for the faith you're putting in our university. Thanks to my great university colleagues for understanding how important this opportunity is for us. And let's see this as an enormously important possibility to role model and to show other universities, other policy makers, how we need to work together to save our planet. And there's no time to waste. So thank you again for giving me this opportunity. I wish you a great conference, and let's keep working together on implementing everything that you're going to be thinking about today and beyond. Thanks so much.
We are now moving to the first session of the day. Dr. Nirmal Kamal, Head of Evidence and Analytics for Health Security at the WHO, will be introducing you to this new framework. I give you Dr. Nirmal Kamal to discuss the framework. Thank you.
Thank you, Professor Brown. I'll be introducing Health System for Health Security Framework. So my presentation will cover background, why we are working on it. And I'll talk about its components and introduce its elements. And then I'll briefly touch upon the concept to the action. And then I'll be touching upon the challenges and the way forward in the slides. As part of the background, I just want to highlight that we published a paper analyzing the IHR core capacities for operational readiness for COVID-19. And we noted that half of the countries are not operationally ready. And then at the same time, we also noticed that there's a significant gap that we identified during this crisis. And one of the scoping review showed that health system and health security are often treated as a distinct fields. And this siloed approach presents a lot of challenges to health governance. So this is where we thought that this is very important framework to bring health system and health security together. I just brought some clips from this crisis. These are some news in a social media and in the media. And you can see that around 17,000 health workers have died due to COVID. And we are seeing a lot of hospitals lacking oxygens. And there are challenges of ICU bed shortage. And then there's this challenges in infection prevention and control. And on top of that, there is challenges on maintaining essential health services. So these all are important of not having a resilient health system or a health system that can support the surge capacity. As a result, we have a increasing mortality and different webs in different places, which is costing trillions of dollars over the years. And then the pandemic, in a way, increasing the poverty in the population as well. Our DG in last year World Health Assembly highlighted COVID-19 is not just a global health emergency, it is a vivid demonstration of the fact that there is no health security without resilient health systems or without addressing the social, economic, commercial, and environmental determinants of health. We have a lot of guidance and documents for health security and health systems, but we need to develop a common understanding what is health system for health security and what are the capacities that are required for health security, which I'll be touching in next few slides. As you know, global health security is underpinned by the international health regulations, and we have WHO benchmarks for IHR capacities, which provide member states suggested actions to develop the plan and implement. We also noticed that with the current benchmarks doesn't capture a whole of society and health system elements also. For the effective implementation of the IHR capacities, we need to have a prerequisite elements from health system as well as from other sectors in order to strengthen and implement those IHR capacity. Therefore, there is an important need to better understand what capacities are required for strong and resilient health system, where the intersections between health system and health security are located, and how challenges at this intersection can be overcome and leveraged for efficient and effective management of public health events. As Dr. Major mentioned earlier in his opening remarks, that we've been thinking about this framework since 2018, and we have an expert consultation in 2019 where 40 experts gathered together and recommended three things. First, recognition of importance of health system for health security. And then it's not only the framework, we need those health system and other sector elements that needs to be in place in order to strengthen IHR capacities. And the expert group recommended to mapping of those WHO benchmarks actions for health systems as well. And we recently, last Friday, we published a paper based on this work, health system for health security, strengthening prevention, preparedness, and response to health emergencies. Now I'll be talking about a detail on health systems for health security. So let me start with the definition. And I'll not go in a detailed definition with health system and health security because we all are aware, and I'm sure you all are aware also. But here I would like to highlight the definitions of health systems for health security. It is an approach that harmoniously brings together efforts to strengthen resources and capacities required for implementation of the international health regulations, components in health systems, and those in other sectors for effective management of health emergencies while maintaining the continuity of essential health services throughout. And COVID-19 had shown those gaps in health system for health security. So what is the purpose and objective of this framework? Is first to support countries, partners, and WHO to be better prepared to prevent, detect, and respond to public health threats and events. and with a primary objective to ensure that all capacities that are prerequisite for health security are in place. Overall goal is to have a community well prepared. We all know that epidemic begins and ends at the community, and at the community level, a same health worker who looks after the curative care, preventive medicine, as well as public health, and the same person will be detecting events and threats. Overall, we want to have a trained health worker who knows surveillance guidelines, who have access to reporting for early warning, and then the facilitating tools like IT. A healthcare worker has access to specimen collection kits and referral mechanism, have a capacity to communicate risk, for especially on locally endemic problems, and access to minimum WAS and infection prevention facilities and logistics, and availability of vaccines, drugs for the local endemic diseases. So this is the ultimate goal. If all the community had these things, we would be able to prevent, detect, and respond to threats on time. Who are the target audience and audience of this framework? Decision makers and public health experts in countries, stakeholders from other sectors, partners, donors, research and academic institutions, and other institutions and community leaders. The guiding principle is it's all hazard approach. We need to look at the risk-based capacity also, because capacity required for one risk differs from others also. We cannot, our Ministry of Health cannot work alone. We need to work with other partners and other sectors also. That's why whole of society and multi-sectoral approach is necessary. And then we need enabling environment to implement IHR capacities or health security capacities from other sectors as well. So this is one of the key slides for health system for health security framework. And when we presented first draft health system, the framework in 2019, before starting the presentation, I mentioned to our expert that this is a Pandora box we are opening, but we want to close it. With a lot of discussion with experts, partners, academia, and with the lessons learned from COVID-19, we try to simplify as to illustrate what is health system for health security framework. So we have IHR capacities with the technical areas or core capacities as defined in IHR M&E tools and benchmarks. We have a health system, 6 building blocks: service delivery to health workforce, information, financing, medical products. But we also need a contribution from other sectors. I would like to take an example of infection prevention control, which is so key important that should be in place to manage COVID-19 also. So as one of the area that IHR is also looking at is IPC. And for this proposed, there's a huge prerequisite elements comes from the health system. There should be a provision of IPC in all service delivery mechanism. There should be a health workforce who are well trained for IPC. There should be adequate information to manage those IPC. Financing and governance of IPC is so important, and not to forget those medical logistics and other logistics. As well as there should be an equal contribution from other sectors. If we don't have a safe water supply in a health facilities or in any places, then we have a limitation to maintain infection prevention and control. So once all these things are in place, then overall outcomes would be health security and health system and other sector capacity that work in synergy to meet the demands imposed by health emergencies, including public health threats. With all these in place, we can achieve the goals of improved health security. As you might have heard from independent panel report that there's a recommendation not to have another pandemic. So not to have another pandemic, we need to improve health security. We need to have a health system that is responsive to the events. We need to ensure that even in the emergencies, essential health services are continued. So ensure the resiliency of the health systems. We want to ensure the social and financial protection, as well as we want to improve efficiency and overall healthier population in this planet. There are a lot of initiatives also. So we need a support from, and there's a supporting role of common goods for health, because Ministry of Finance and the financing terms, these are the terminology that they understand, and we need a investment in preparedness in health system for health security to break the panic and neglect, panic then forget cycle of the preparedness. With all these things in place, we will be able to strengthen essential public health functions required for health security. And we can achieve this because, as I mentioned earlier, that epidemic begins from community and ends community. So primary healthcare approach is so essential and vital for health system for health security. With all these in place, we can concurrently achieve universal health coverage as well. To summarize all these components and to demonstrate to show the interaction of these health systems and beyond health sector elements, we use this infographic, which we published in last week paper also. So you can see the interlinkages among those components within the health security, with the health systems, and with the other sectors. How to implement the framework? I'll briefly touch upon the benchmarks, because we are updating the WHO benchmark for IHR capacities with adding the elements from health systems, those prerequisite elements, as well as from other sectors. We have a graduated approach here, which we've been using for monitoring and evaluation of IHR capacities, from limited capacity to sustainable capacity. So we will have actions that country, member states, and partners and WHO need to support on implementing those actions to gradually mature the model with the overall goal of achieving the sustainable capacity. I'll take the example of a benchmark for infection prevention of control, which we mapped for health system elements as well as for other sectors. This is how we are updating the benchmark, which is almost in a final stage. It will go through the web consultation process very soon. I'll take an example of farm to fork. It is essential to maintain the infection prevention and control from farm, where animal health sector need to ensure to prevent any spillover of zoonotic events to humans. And then there's a private sector's role to maintain IPC, or industry role to maintain the infection prevention control when delivering those animal products for the people. And at the same time, if there's no safe water supply or sanitation system from other sectors, then we will have a bottleneck of maintaining IPC. So this is how we are envisaging and updating our benchmarks with the inclusion of health system elements as well as other sector elements. As I mentioned earlier, we want to have those 6 to 7 elements in a community level, but there are different national system, public health system in countries where sub-national level, from national to sub-national or intermediate level, some countries have a province and state. There should be infrastructure and institutions to support community to function well. Not only that, there are supranational level function also, global and regional framework strategies that can help. We noticed also that countries who have the regional strategies in place, like APSID in Asia Pacific and IDSR in African countries, in Africa region, it had help on strengthening health security capacities significantly, which we also reported in a midterm report of WHO last week. So this concept, how we are going to bring to action. So we need information, the status of health system for health security. We are not going to create another assessment process, but we have already existing assessment process we'll bring together. We need to develop or update the plans to include these elements within the National Action Plans for Health Security, or IHR, as well as National Health Sector Plan, which country have 5 to 10 years strategy plan also. We need to implement with adequate resources and technical capacities, and we need to monitor this implementation so that process improvement approach is maintained. There are a lot of challenges to implement health system for health security. We have categorized in 4 broad headings: leadership and governance, M&E, financing, and human resources. So for leadership, there is health security is not a priority. When there is an event, emergency, everybody talks about preparedness and health system for health security, but once the event is over, it's forgotten. So this time onwards, we are hoping that this panic then forget cycle will be broken. There's a limited understanding of what is health system for health security, which this is why we are running these workshops, and we will expand this as well. There's a misunderstanding of the core capacities of required for health security. Health security and health system structure are functioning as disconnected vertical silos, which our scoping review has also shown. National health policies, strategies, plans, essential package of health services do not or only rudimentary address health security. For M&E, there's a lack of data collection. More than the data collection, there's lack of analysis also. This is where we need to improve and use the existing data for decision making. There is a huge limitation of research capacities overall preparedness. This is where we are working on preparedness research and development, focusing on operational and implementation research other than vaccine therapeutics and diagnostics, which is covered by R&D blueprint and others. We need to have a sustainable financing mechanism to strengthen health security. And we also have a challenge of costing these elements. What is the cost, or what is the investment cost required for health system for security as well as preparedness? There are not much skill sets available in many member states. We need a trained expert. We need to tackle this also, and we need to increase the awareness, especially in the decision making and policy makers. So what's next? We will be publishing the framework very soon. We have updated the benchmark. It's going through the consultation process. In addition to the benchmark, where we are telling what are the actions, but we have a reference library within the benchmark each action, so that country or member states partners will have a tool, a reference how to implement. For instance, if the action is to strengthen event-based surveillance, then that action will have a link with the event-based surveillance guideline, training package, SOPs, and others. It is part of the IHR benchmark tool online portal also. So we'll be using a lot of existing data and analyzing them so that it can be used for decision making. And then we'll subsequently be developing monitoring evaluation tools, advocacy tools, and training curriculum as well. I would like to share that we are working with the Leeds University with Professor Brown and his team to develop the short course as well as master's course for health system for health security. So our unit and our department in preparedness division, we are also working on dynamic preparedness metrics, which brings all the health system and non-health system data, because we want to see preparedness status as a dynamic mode, because it changes according to the risk, it changes according to the status as well and the event. As well as we are working on preparedness economics, because we need to look at what are those investment are going, what are those return on investment. We need to conduct economic evaluation, and we need to come up with the investment case. So we are working on that. We've been working on developing framework for health security preparedness research, development, innovation. And recently we have launched a small scale research grant in collaboration with AMRO, WHO, AMRO, and TDR for operational and implementation research for preparedness, IHR, and health security. We'll be expanding the same to other regions as well. So this is my second last slide. So the framework defines and explains what health system for health security and its interrelations and dependencies between health system and health security are. The updated benchmarks for IHR capacity explain how to build and strengthen health system for health security capacity at local, national, and global levels. We are analyzing data. We are partnering with a lot of institutes because we cannot do everything ourselves. So we will be working on generating more evidence on this one. Health system for health security framework, its tools and actions can support investing in health and other relevant sectors to strengthen health security and make the world a safer place. I would like to take this opportunity to thank all the experts of member states, our colleagues from WHO regional offices, both from health system and emergency programs. Experts participated in the WHO consultations, University of Leeds and other partners, technical teams of WHO headquarters and our leaderships and management team, senior management team, and our team members from evidence and analytics for health security unit, and all those references that we use for the framework as well as in these slides. So with this, I conclude my presentation and I hand over back to Professor Brown. Thank you.
Thank you very much, Professor Brown, and thank you very much as well, Dr. Kandel, for an absolutely marvelous presentation. Were the HSS teams within WHO, the World Health Organization, engaged in this work as well, or was it work done mostly through the emergency team?
First, this is the joint work with the health system teams also, not only in headquarters, it's also from our regional office. The framework was shared, all the regional office and regional office colleagues also shared with their health system counterparts also. And this is the product of one WHO, not in a silo. And we are mapping those health system elements in consultation with our health system colleagues here and the regional offices as well.
Will the short course on health systems for health security eventually be available free and online?
We want this to be free and online. Over to you, Professor Brown, to add additional point.
The answer to this is yes. It will be a micro-credential embedded within a larger MA course. It will be online. It will be free and accessible to all. It's in the process of being designed, and we hopefully will have it rolled out within 12 to 14 months.
How is security understood? In other words, what value does this term bring that others don't?
for health. When we say our health is secured, means we are detecting threats and preventing them becoming of epidemic and pandemic. When it becomes epidemic, we manage the epidemic as well as prevent of happening is like a pandemic. And even if pandemic happens, we also ensure that there are other epidemic prone diseases and other health related elements that we protect of happening it. So in a simple term, this health security is to ensure that first, stamping the fire at the source. So if we manage to do that, the thing is this, because of early warning systems and early warning mechanism, countries, member states, we all are preventing a lot of outbreaks, but that doesn't make it to the news. But what it makes to the news is those which become epidemic and pandemic. We want to prevent, and we don't want to have those news anymore. And this is one of the recommendations of independent panel. We don't want to see any more pandemic.
The indexes for IHR preparedness were not predictive of performance in the COVID pandemic. How has this observation impacted on the framework?
So thank you for this question. So that's why in my second last slide, I put the dynamic preparedness metric. So one of the biggest lessons learned we captured is that we need to look preparedness status in a dynamic mode. And this is where we are bringing not only IHR capacities scores, we are also bringing health system elements and also those interdependencies. Like an example I put for infection prevention and control, where animal health sectors has a huge role, private sector industry has a huge role, as well as water and supply system. So we are bringing those elements together. Good news is that we have already established a working group to develop that metrics. So, but it's not going to be an index to rank a country. What we are doing different is based on the preparedness status, we are linking that to the benchmark actions. So when any member states or any place where there's a reduction or fall in the preparedness status for given risk, then these benchmark actions can be useful to identify what are those 10, 20, 15 priority actions that country member states can put in place in order to manage or prevent any epidemic or pandemic.
COVID has taught the world of the importance of health security more than ever, but also the importance of multi-sectoral collaboration. Is there any plan to communicate the study findings you mentioned to the respective countries' ministries?
Yes, definitely. And, in the beginning of the pandemic also, when we did analysis, we shared the information with the regional office, and regional offices are supporting countries with the available information. And this is our routine activity that we will do. And we need to do a lot more because there are a lot of people quite often says there's no data available. And what we are now saying is data are there, but we are not analyzing enough. So this is why we are strengthening that capacity at our level, at regional office, at country office, and at the member states level also. So just to add, we have launched a IHR monitoring evaluation training because, one thing which needs to be in place in all offices, especially those who are responsible for health system, for health security, IHR, to have a M&E capacity, because when you are monitoring, you are noticing, and that capacity is limiting. That's why we launched M&E training. And with this COVID-19, with the new normal situation, we have digitalized that IHR M&E training and will be launched formally in next 2-3 months. Last month, we finished the piloting. With this training, face-to-face training was developed in 2017, and 2-3 regions we have already conducted training, and those countries are also using these materials to train their workforce on M&E. What we want is countries should be able to detect their strengths and identify limitations, and they can manage that themselves, so that we have a health security in place in order to manage those preventable epidemics.
How does health systems for health security link to those initiatives already existing, like risk assessment, health, and the health system resilience agenda?
When health system for health security is in place, the outcome of that is resilience. This is a framework, but our main goal is identify those health system elements that needs to be in place in order to ensure those IPC capacities are in place. From IHR or health security point of view, we cannot strengthen the IPC without the health system capacity in place, because IPC is required for intensive care unit, in hospitals, in primary healthcare, for managing any kind of diseases, not only those which has potential threat for health security. So these all are linked. And for me and for us, resilience is the outcome of the health system for health security in place, especially for epidemic and pandemics.
One Health, the intersections between human, animal, and environmental health is clearly emergent in the framework, but the language of One Health is not very explicit. Was the framework developed in collaboration with partners from, for example, the FAO and the OIE?
That's a very good point. So we've been working with the benchmarks, with the other IHR M&E tool, with the partners also as part of the whole of society approach, because that's the guiding principle. We have consulting and bringing all those relevant sectors, One Health and other sectors as well, because we see a lot of interdependencies, one of the lessons learned from COVID-19, and we need to bring them together.
There's a question here, will it be in different languages? I'm assuming the short answer is yes.
Yes, gradually, because we will definitely.
Are there any pilots of the course planned?
Definitely, once we have developed that curriculum, we'll definitely pilot it. Like I mentioned, for M&E training, we pilot it, but I hand over to Professor Brown.
That's the thinking. To work out work out bugs and other things like that that may develop, especially with a very large online course, which has its own sets of parameters you have to consider.
How can countries like Nepal benefit from this framework? What are the critical capacity gaps in the context of the pandemic to enhance health security from health systems perspective?
Thank you for this question. And I also come from Nepal. So it's not only for Nepal, it applies to all countries. One of the things which we found from this pandemic is even those well-advanced countries with health systems, we found the limitation on resource mobilization, surge capacity mobilization. This is where we need to identify those key elements that needs to be in place in order to strengthen health security capacities. So one of the things that we are not only developing the framework, simultaneously we are working on, because at the ground level, at the field level, at the implementation level, framework is overarching things, but what we need is those key essential elements. What are those actions that country needs to put it in place so that the system is robust and responsive and resilient during the emergencies?
Was there a consideration for including the IPC within animal health, as shown on the slide, in the food safety technical area? It may well fit well into the farm to fork concept.
This is why any suggestions and ideas is open. That's why we are putting our benchmarks for a web consultation, and we'll definitely consider, and we'll discuss with our food safety team, our FAO team, and others also. But point taken, thank you.
USAID worked with the World Health Organization and recently hosted a meeting on the same topic as this meeting. Have you seen this work, and will it be included in a collection of literature on this topic, as you mentioned, collecting more literature?
Definitely. And our team, our department was part of that workshop also. And USAID colleagues are also joined today and tomorrow also, because we have a small group workshop to move forward things with the partners and academia, and colleagues from USAID is also joining.
How does the framework address the challenges of concurrent emergencies, particularly in communities, as I see what you've described as mostly focused on epidemics and pandemics?
Two things here. One, because of current pandemic, I highlighted the example of current pandemic, but I also mentioned that these capacities should be in place in order to prevent those epidemics. And as I mentioned earlier, prevented epidemics never came to the news. And when this health system for health security, and if you notice that the 6 trained person with the access to reporting, specimen testing, risk communication, and logistic at the community level, that is, if those things are in place, our health workers at the community level will prevent those epidemics. And so it's not only about epidemic, this is all hazard approach. And if there is an earthquake, and this is the same community health workers will manage the earthquake related injuries, but at the same time also manage the potential outbreak of a waterborne disease or respiratory borne diseases also.
Which I think comes back to one of your challenges. This is seen as a cost rather than investment.
Yeah, I know, and this is a big challenge. And two things here I would like to highlight. First, every pandemic emergencies is opportunities also. And with the COVID-19, we all are expecting that this panic then forget cycle of preparedness will be broken for forever. And it's not only partners, countries also themselves put their domestic resources, a sustainable investment for health system, health security, because we have a lot of example also. And the second thing is our colleagues from health system, from health finance, health governance and finance team, who are working with the language that Ministry of Finance understands, which calls common goods for health, and investing in these common goods for health will help ensuring sustaining resources, investment for preparedness, for health system, for health security, so that countries will be able to mobilize, manage, and the recurrent cost, as well as respond emergencies on time.
Since health security is heavily influenced by the foreign policies of HIC countries, how can the framework ensure that health security priorities of donor countries are aligned with strengthening the health systems of recipient countries?
It's a very important question. All the questions are really great. And Jose, you are really putting this question nicely, which makes my life easy also. So I can answer quite quickly also. Yeah. So the first thing is, this is why the dynamic preparedness metric is so important, because, you know, the health security capacities that is required for country X in Asia, country Y in Africa, and based on their risk is different. That's why we need to contextualize, we need to understand the context, country's background, and other elements also to better understand. Because this is one of the lessons learned from COVID-19 also, because we cannot advocate only the tool that has a principle or that follows that one size fits for all. It doesn't. So this is where we will be working with, because this is where our strength is our regional office and country offices, where all the regions are different to each other also. And this is how we will be working with regions, with the regional context, and even the dynamic metrics, because the information should be there in order to identify where are those gaps, to build those, implement those actions to strengthen health systems for health security, preparedness, and ISR capacities.
I'm curious as to how different countries view their national health security compared to global health security, and how the framework attempts to communicate the balance between nationalism and global cooperation.
This is another important question. So we've been talking about global health security, but now with the COVID-19, now there's a concept evolving as a national health security. And this is also evolving concept because it's also links to the community preparedness, community security also as part of community health security. Because, you know, we look at the bigger picture or overarching things, then miss the community level things. And this is why I want to reiterate again the same thing. If that means national health security is protected, global health security is protected. So the basic elements of national health and global health security is community preparedness and community health security.
How confident are you that member states will adopt and implement the framework, given the challenges that you mentioned?
I think the biggest lesson learned from COVID-19 is that we need to bring health system and health security together. If we just come with the framework, it may not work, but this is why we need a tool that will provide those health system elements or other sector elements that needs to be in place. So this is where these updated benchmarks with the health systems elements in it is so important, because at the end, a program manager or the Ministry of Health who implements the program, they need those elements. Okay, what are those key essential elements that needs to be in place in order to strengthen ISR capacity or health security capacities? I think with that tool, it will be useful, but I wouldn't say that the tool is a solution for everything. This is where we need to use the real-time data. This is why we are working with the dynamic metrics. This is where we need to have a lot of operational and implementation research. This is why we are working on preparedness research and development, because there's not much focus on interventions or operational and implementation research. How we need to engage community in the emergency, how we need to communicate message in the community which is reluctant. Even wearing a mask is a simple thing which we have. How we can break the social dilemma in the community, because one of the biggest challenge we found from the COVID-19 is breaking those social dilemma. And this needs a lot of intervention, operational and implementation research to come with the solution. And this is context specific. The community engagement principle for Nepal and for Ethiopia would be different also. So we need a local level interventions and operational and implementation research also to tackle it.
Usually health systems in lower and middle income countries are well organized at national and regional levels, but leave lower levels behind. Does the programme take into consideration capacity building at community and sub-district levels in various countries? And does it have plans for sustainability?
I think one of the slide which I highlighted with the 3-4 labels, community, intermediate, because there are some countries that don't have a intermediate label, but there are like national, sub-national, and community label. We need to, because to ensure community preparedness, to prevent and detect those threats and events, community has a capacity, but they need an infrastructure to support at the higher level also, like a referral center for testing, referral center for managing cases. So definitely, that's why we also mentioned that primary healthcare approach is so important, which can help to strengthen community preparedness as well for the national health security.
What does the health systems for health security framework address that a health system framework, for example, the World Health Organization's 6 building blocks, cannot address on its own? Does this mean that we may need to have various health systems for frameworks for other health and healthcare issues?
That question, and one of the slides where I saw the interaction between health system and health security, and this is where, again, I will be repeating the same thing, and we are following on those building blocks, because the 6 building blocks, as its title, it's everybody's business. It's business of all the health sectors, including health security also. So we are building on this one. Only thing what we are trying to identify is highlight those health system elements that are prerequisite. Without that, and IPC is a classical example and easy to understand with this current situation also. So this is where those elements, we want these things to be in place so that during emergency, we don't see any such kind of problem. And those news clips, I don't have to put those news clips in my next presentation if we have those things in place.
Knowing what we know now and in hindsight, do you believe that this framework would have limited the disproportionate effect of COVID on Black and ethnic minority individuals?
2 things I would like to highlight. Our department, under the leadership of Dr. Stella Chungong, our data and COVID-19 has shown that there is a lot of disparities, not only racial, there's a gender disparity also. And this is where there's a working group created to bring gender and this kind of issues in mainstreaming in the health security and IHR. So working group is there for managing these kind of things. And we need to have this one. And it's not only that, we have been seeing the vaccine related inequity as well, and not only other forms of discrimination at the time of emergency. And you can see our pressure in WHO pressure, our DG is highlighting those inequities quite regularly.
What do you think about other relevant sectors in this framework, given the feedback loops between health, healthcare, and most, if not all, aspects of society? For example, national employment rights determine the ability of citizens to adhere with pandemic response policies. But then also, how far does the scope of health security extend? Does it include natural disasters, biosecurity, and even climate change and air pollution, for example?
Yes, but in 2 ways. One is we need those information, because what are those interdependencies? If we don't have that information, then we cannot manage. So as part of the information generating, this is what the dynamic metrics, where we are bringing socioeconomic vulnerability, ecosystem, climate change related vulnerability, population vulnerability in it. And the second part is, we as a Ministry of Health or of Health cannot manage everything, but at least we can bring those information. And this is where, if there is no water supply, without the support of the water and sanitation department, it's very difficult to ensure the quality water supply in all health facilities. So this is where we need to bring, and we are bringing this information as part of this work, as part of our dynamic metrics, because first thing is we need to have information where there is a gap and how collectively we can address. And COVID-19 is another example where, looking at the situation now, every sector is contributing. And right now, if you look at my own country in Nepal, now the security sector, army and police are all supporting government and Ministry of Health on managing these hospitals and other things that's required for the control of COVID-19.
What are your plans for technical assistance?
First thing is, we will disseminate this through our regional offices, because we are not creating another program. This is part of the existing program. It's only that we will be highlighting this importance of health system elements for health security using the existing resources. In the regional offices, country offices, we have emergency focal point health system focal points who are supporting, and we will be using the same resources.
IT competencies have always been lacking in health professionals in developed and less developed countries alike. In your framework, how important is it to improve IT competencies and the adoption of IT at different levels of implementation? I ask this as I didn't see it being mentioned beside the reporting tool at community level.
Thank you for this question, because we've been discussing and working with the IT tech companies and other things to bring IT and the different types of applications also. So one of the thing which I put it in the slide on the dynamic metrics, we want this as an application base. It will be using publicly available data source. So, and we'll be using even a blockchain technology to bring all those information from multiple places together. And then country can also use their own data in those applications. There's a silver lining of pandemic is that I think with this video conferencing and using IT tools more frequently than before, we all are now using more applications than before. So I think this is another opportunity, and we definitely rely on it. In the full document, we've been using different technical supports and these things, but definitely thanks for this one, and we will incorporate and mention explicitly the role of IT and digital technology for the framework, for the benchmarks, for the metrics, overall for the health security.
Could you unpack what you mean by system capacity? COVID showed that, in theory, strong or well-developed health systems are not necessarily resilient. Health systems need capacity to absorb, adapt, and transform in order to be resilient.
Interesting question. So put an example. Here the system capacity linking with the resilience. So countries who are managing COVID-19 are mobilizing their existing resources, health resources, other resources to tackle the COVID-19. But at the same time, you notice one of my slides, third slide, where our WHO Pulse survey shows that there's a huge disruption of the essential health services. As I showed in the slide, there's a huge reduction of poverty, but there will be a lot of reduction of many health indicators because of the disruption of the health services. And this is where building a system capacity is so important. If these systems are in place, even with this big crisis, we could maintain those essential services. And this is why resilience health system, this use of resilience word is so frequent, because we need that system in place. And so this is how we see system capacity.
In what ways will health systems for health security seek to tackle the trust and legitimacy problems apparent in global, national, and local institutions?
If the framework is used along with those actions, because when we implement those actions, it will bring those sectors together also, even the hierarchy of the system. And with that, the same box, community, intermediate, and national level, because there is a linkages. If community has those capacity, if there's higher up doesn't have those capacity, then it will be difficult for community to tackle or manage, even they detect the threat. After detection also, if the community is not supported with the other higher ops capacity, then there's a danger or a risk of having that threat to an event. So this is where at the field level, at the implementation level, the actions, those elements, and one other thing is because of the ISR monitoring evaluation framework and external evaluation process, National Action Plan Health Security, which one thing which helped is to bring all sector together. This happened following the JEs and following the National Action Plan for Health Security. We published a paper also with a quote from different countries. One, I can give you an example. I was leading the Balochistan province joint external evaluation while discussing, it's a classical example of One Health as well as the multi-sectoral coordination. And then the provincial health officers, they don't have a veterinarian to support for genetic related events. And then the provincial health officer from the animal health side said, okay, next day I'm going to send you one veterinarian working with you. And I think even during the assessment, that kind, and it is quoted, we quoted in our Lancet paper also. And this is the classic example. And when we implement those actions, when we discuss about the actions, I think the sectors come together at the implementation level.
Gentlemen, we are up against time. I think these questions have been very good. I think they press upon a lot of the key issues that we have been thinking about and debating with this framework. It's still a work in progress. And I think that these type of questions are going to inform our thinking in the future. So I'm very, very pleased with the level of the questions, the detail of the questions, and thank you all very much for engaging.
So let me first introduce Jessica Martini. She's a lecturer at the School of Public Health in University of Brussels in Belgium. She has a multidisciplinary background in political science, development studies, and public health. Our next speaker is Professor Garrett Brown. He's a chair in global health policy and co-lead for global health research at University of Leeds.
Our scoping review is meant to look at what is the current research on health systems for health security. And this was done with NERML's group to try to see what was out there in terms of the linkages between health systems and health security. Let me give you a bit of a glimpse of the review. The project team who put this together is myself and Jessica, of course, but like all good projects, there's always many people involved with it. Gemma Bridge and Jim Kon from Sydney, and of course the EHS team over at the WHO also had their inputs onto the project. I think Nirmal mentioned this in his presentation, but intuitively, if you just look at the literature more broadly, there seems to be this separation between health systems and health security, and that the two fields are often treated as these sort of separate silos. We wanted to test that a little bit in the scoping review. What do we mean by these two things before we start? Well, health systems are usually including of the 6 building blocks. Some add a 7th building block of populations as kind of a binder of all the various blocks. There's tons of health systems articles and literatures out there. Health systems is very much an established area of study. You can see that with Health Systems Global, and there's all sorts of organizations that focus on health systems. You also see in the literature another group, the sort of a health security focus. Broadly speaking, health security is the activities required to minimize the danger and impact of acute public health events that endanger the collective health of populations living across geographical regions and international boundaries. Particularly sort of at the end of the 1990s onwards, there was a large sort of birth of new literature on health security, different ways of thinking about health security. Is it more national-centric? Is it more human-centric? These type of debates going on. And there's tons of various journals that deal with that. So they're often treated as two different fields, and we wanted to test that a bit. Like, what is the scope of that? So here are our research questions that sort of underwrote the entire scoping review. What is the existing evidence linking health systems to health security? We just wanted to see what the field was like. Again, there's a lot written on this, and a lot of the health security literature does mention health systems, but sometimes it's in passing or it's a very surface level. We wanted a little more about explicit links between these concepts. And we had 2 sub-questions that also directed our research. One is, what are the essential elements and characteristics of a strengthened health system for health security? So in the literature, when people do make explicit links between health systems and health security, what sort of essential elements are they focusing on? What sort of characteristics within the literature are being drawn out as important characteristics of a strengthened health system for health security? And B, what examples exist to help demonstrate how these improvements in health systems can actually lead to improved health security? Outlining our project overall, we have a couple general observations that kind of answer the primary researcher question. And then we will give you some examples of what we found sort of answering the sub-questions A and sub-question B, although we can't obviously be exhaustive of all the examples that we found in the review. I'll highlight some ones that we thought captured the linkages most clearly and maybe most fully. So what was our search strategy? Our inclusion criteria was that health systems for health security were associated concepts, and that they had to be made associated concepts in the literature. So one of the limitations of the project, obviously, is that if someone was talking about health security and mentioning things sort of related to health systems, but not explicitly talking about health systems, they may not have been picked up, but ones that are making explicit links are picked up. We wanted peer review evidence. The journal articles that we looked at were in English. Our time frame was 1999 to 2020, and it was at the national level. So although we did pick up stuff at regional and global level, and we did include that in our search, we didn't focus on that in the review itself. That's going to be for a later research project. How did we filter this out? We ranked everything according to high, medium, or low. And high made explicit links between health systems and health security, and gave lessons on elements and characteristics and case studies. So those articles were rated as high if they made those things present within the article, particularly giving a case study that kind of demonstrated the links that they were talking about in the article. A medium one, relevance, would make links between health systems and health security, but did so with pretty general reflections about the relationship between the two and did not provide any case studies. They did talk about certain characteristics or were focusing on certain parts of the health system, but didn't actually do any in-depth case study analysis of that relationship. And then low was made few links between the two concepts, maybe had some minor examples, but did so in a very superficial way and didn't quite get into the leaks deeper. Using this relevance criteria, we found 343 articles, of which 204 were high or medium relevance. So here you can kind of see our search method prior to finding the 343 and why we had to put in the relevance criteria and why we thought that was important is because it generated over 27,000 articles. And that's just too much for us to do, particularly since this was a rapid scoping review, which we had to do in a tight time frame in order to help evidence the framework with the WHO. These are the sources that we searched: PubMed, Scopus, the usual suspects. But what we did that may not be usual is that we tried to balance medical focused journals and public health focused journals with social science or other disciplinary journals in order to get a broader range. Because health security is so complex and amorphous and can include so much, and same with health systems to some degree, that we wanted to make sure we got a broad range of sources that we looked at. We have a breakdown based on building block. So what we did is we categorized those 343 into what building block we thought they best represented. Then we screened those based on our relevance criteria, in which we got the 204 high and medium, and then the low relevance ones. You can see at the bottom square what we ended up analyzing and what building block they ended up being within. If you look at the next graph there, the count of publications per year, we did this just to kind of track how this relationship between health systems and health security was playing out in terms of when they were being published. And I guess the notable feature on this graph is that after the Ebola outbreak in 2015, you see a massive spike in this kind of research, which was trying to look at health security and health systems as being interrelated. So here are our main results, and Jessica, over to you.
Thank you, Garrett. So the idea here is to present the main results that we found in the scoping review and to put them into perspective by giving some food for thought for each set of results. And for this, I will hand over to Garrett again. So the first result was the clear tendency in the literature to focus on acute health emergencies. If you look at the table, you can see that the majority of articles addressing a specific public health event or topic were related to infectious diseases, and in particular to Ebola and the 2014-2016 outbreak in West Africa. This case was used to point the weaknesses of a health system in low-income countries and to point also the failures related to global health governance and its inability to effectively respond to Ebola. As you can see, natural hazards and biological and chemical threats, including terrorism, came second and third position, even if they were addressing to a much lesser extent than infectious diseases. What we would like to draw your attention here is the fact that events, topics, and events that are recurrent and that require long-term approaches were addressed by just a few studies, 2 articles dealing with non-communicable diseases, and only 1 article addressing maternal and child health. And paper on NCDs in particular pointed out the imbalance existing between the priority given by international health security initiatives to infectious diseases and bioterrorism, and the fact that today the leading causes of mortality and mortality worldwide are not infectious. This first tendency raises a first set of questions about the linkages made between health system and health security, and Gareth, I'll let you discuss this first result.
This tendency to focus on acute health emergencies sort of raises some discussion points then in our scoping review paper. Our question is that it seems to undermine or ignore preparedness, and also not link preparedness to routine health systems, the baseline readiness of health systems and being prepared for these. So this focus on health, acute health emergencies very much, we thought, misses some of the important points that the Health Systems for Health Security framework is trying to address, which is it's not just about response. It must also seriously consider prevention. What can you do to prevent these things in the first place? And then also preparedness, to be prepared for these eventual epidemics or pandemics. And that thinking about the routine health systems as part of that preparedness seemed to be lacking in a lot of the literature that we looked at. Not all, and we'll get to that later, but as you can see from the table, but also this is one of the big findings we found, and we thought that that was worth pointing out and discussing in our paper.
So you can turn to the second result, which was the second clear tendency in the literature to cover mostly low and middle income countries. You can see in the pie charts, almost half of the publications were related to specifically to low and middle income countries, while only 70% addressed concerned only high and high income countries. And there was 14% of the publication which adopted a wider comparative perspective, including data and examples from countries with different income levels. Among the publications which had specific geographical focus, Sub-Saharan Africa was the most covered, which is partly related to the fact that to the attention given to the Ebola crisis. What is also significant here was the fact that publications related to North America or Europe mainly dealt with the capacity to respond to pandemics or infectious diseases imported from abroad, like Ebola, but also Zika, for example. And they also dealt with travel medicine services and with actions that are or should be taken internationally to strengthen global health. So in other words, this paper focused on external threats and on strengthening a system in fragile context, rather and not on health North America and Europe health system in their own. This brings us to a second reflection, and Gareth, please tell us about this.
So what this sort of brought to light for us was that the South is a potential source of the global health security problem, or at least it looked like that was being framed as the case. So in the case of the North America and European articles, it was very much about a pathogen that is brought into the country. So where there were links with health systems, it was very much about health systems in the country of origin, and not so much about health systems in, say, North America or Europe. This taps into a large critical literature on health security that is out there. And this tends to suggest that, well, health security is sort of a militarization language. It tends to always talk about surveillance, etc. Tends to talk about us and them. It's potentially imperialistic or Eurocentric. And so we did find that the way that the literature pans out about what was the subject or the area being studied helps, or at least kind of supports, some of that critical literature on health security and paints a picture, or at least helps support the critical narrative that a lot of what we talk about when we talk about health security is a sort of a Southern problem, and that this ignores that high-income countries can actually be also countries of origin. And if we think of COVID-19 and the variants, so we have the California variant, the UK variant, India, South Africa, Brazil, these wouldn't be necessarily low-income countries. So we would have to think that the scope of this needs to be broader than it has been before. Okay, Jessica, next slide, please.
Okay. The third result was the tendency of a paper dealing with health security to focus on the technical capacities of health system to respond to acute health emergency. Usually this was done giving a recommendation that or analyzing a single building blocks and often ignoring more health system approaches. Just to be clear, if you look at each building blocks, for example, we can see that at least 3 building blocks were focused on surveillance. Health information systems, of course, a lot of paper discussed the capacity to detect, alert with early warning and respond to emerging risk. And linked to this, a lot of attention was given to the capacity of human resources to collect and analyze data and to the necessity to put in place training in epidemiology, for example. And finally, the third building block is that of service delivery. Many papers discussed the delivery of surveillance services and linked to this, the delivery of laboratory services. And quite surprisingly here, the delivery of healthcare services was not covered at all. If you turn to medicines and technologies, measures like vaccines and pharmaceutical stockpiling were most addressed. With regard to plants, the great concern was the developing of plans to prepare and respond to future crises. Finally, about financing, several papers highlighted the fact that there was a prevalence of ad hoc and earmarked funding, that it was difficult to transfer subsidies, for example, from humanitarian programs to development programs. This was just a brief overview of some conceptual links that were done. And Garrett, you can discuss this general overview.
What we found with a focus on technical capacities to respond to emergencies was that it undermined discourses on prevention. And oddly, under the governance and leadership building block, there was a lot about having strategic plans in place, but far less on governance mechanisms and the key sort of interlinkages that needed to be done between various governmental agencies to institute those plans. Now, each plans are different, of course, but the literature itself, when talking about the necessity of having strong governance and leadership in health systems for health security, tended to focus more on plans. And we thought that this undermines key ideas about prevention, but also key theories of change problems about governance mechanisms. So how do you get to point A to point B? And it also raises two other interesting aspects that we'd like to highlight. One is that reading this literature, one gets the impression that these health emergencies are treated as a kind of form of exceptionalism, that what you're really talking about is locating this exceptional situation and responding to it with exceptional mechanisms. And that tended to be very short term with a view on, immediate kind of health security. Now, this links back to Nirmal's presentation about the focus more on health systems resilience and its ability to sort of prevent and prepare for these shocks, instead of this sort of the literature that we found, which seemed to be looking in the direction of, these are exceptional events and we treat them exceptionally. And that, again, undermines some of the key health system preparedness and prevention strategies that might otherwise be quite helpful, as we've seen in the case of COVID-19. No health system performed perfectly well, and you're only as strong as your weakest link. And so this idea of an exceptionalism, we think, prevents better long-term thinking.
The first result is about a minority of papers which adopted more oriented on health systems and which made links between health systems and health security by using a more holistic view based on systems thinking and long-term approaches. And they did it by using two concepts, the concept of resilience and the other one is universal health coverage. So firstly, about resilience, we wanted to briefly present the work done by Barraza and Bowen Gilson, which was included in the review, which invites to take into account three intertwined types of resilience. Planning resilience, that is the function of planning for and preparing for future crises. Adaptive resilience, that is the capacity to absorb and adapt to acute shocks when they break out and to maintain key functions of health system during acute emergency. Last but not least, everyday resilience, that is the capacity to absorb and adapt to recurrent, to routine and chronic stresses, and to maintain the basic function of an everyday health system, the routine health system every day. And another message that was important is the idea that resilience means adaptation and transformation, and is not simply bouncing back to the old normal, but moving forward towards a new normal with stronger health system. Well, the second set of papers which adopted this more global view of the linkages between health system and health security was the papers dealing with universal health coverage. And we mention here the work from Frank and Gomez-Dantes, whose idea is that universal health coverage should aim to ensure three types of security: epidemiological security, healthcare security, and financial security. And this comprehensive view of protections allow to address financial problems, but also healthcare issues and epidemiology risks, and combine both individual and population health security. This vision is most that of middle-income countries, low and middle-income countries, and has inspired reforms in countries like Mexico or Thailand.
As part of sub-questions A and B, we want to define some examples that demonstrated system improvements for security. So that was one of the aims of our study, was to locate 12 case studies to use within the framework as examples. We looked for 2 examples per health system building block. Then we did deeper analysis of those case examples to try to find key components. We don't exhaust all the examples, and I can't go into all the depth, but basically one of the ones under governance that came out in multiple papers was about Indonesia. They linked a national health security plan to a development plan. They had pre-designed governmental mechanisms and communication strategies involved. And again, the key thing was linking health security with development plans. And that was seen as providing good governments, and of course with financial input to back those. Under financing, there was a study in Thailand that again looked at how health systems and universal health coverage were strategically combined for a larger national health security agenda. And that was seen as being a much more comprehensive and long-term strengthening of the health system, with a security agenda also in mind, linking that universal health coverage scheme in 2001 with the Health Security Act in 2002. And we saw similar links between strengthening investments in health system building blocks with universal health coverage, particularly in a lot of West African Ebola responded articles. Health information was another area where there was literature suggesting that basic improvements in the health system would lead to long-term health security. One was that information system improvements in Uganda after Ebola, coupled with community-based surveillance systems and training of local community members, results in much better pickup of problems before they emerge at the national level. Low-tech improvements in the DRC resulted in more rapid and effective Ebola responses. These are just small things in how you can input data, share data, and respond and analyze the data. Integration of national lab systems was quite large, particularly at regional level in West Africa, but also at the national level, that if you can get your laboratory systems to be more integrated and sharing information more quickly and in a more streamlined fashion, that this has health security outcomes. Under workforce, there was a lot on field epidemiology training programs. This would probably be the predominant examples that we found. Also, again, on the importance of laboratory workforce and capacities. Now, this strengthened one of our other more broad findings, that there's a lot on surveillance and laboratory capacities in the health security literature. But that doesn't mean that that's not good for your health systems and vice versa. Under service delivery, we found a couple interesting ones. Lebanon was used as a case study to show that reducing out-of-pocket costs and increasing the number of primary healthcare centers was able to absorb the shock of Syrian refugees between 2011 and 2013, and that these small interventions are actually quite large interventions with reducing the out-of-pocket costs, was able to make sure that the system didn't collapse under the weight of all of demand. In Saudi Arabia was really interesting stuff on how they have not had a single massive outbreak during the various travels to Mecca, due to their protocols that they put in place for vaccination, but also for taking care of pilgrims when they come and to monitoring and enhance their monitoring and surveillance. These things have allowed them not to have a major outbreak, despite the fact that there have been warnings and pathogens of concern during those times. And the last one is access. Indonesia was highlighted as having a component for affordable access to essential medicines as part of their universal health care coverage that links to their national health insurance system and national security plan. So that was one example of how you can combine various elements or concepts that you're dealing with within a health system and within health security with universal health coverage and access to medicines to help your population full stop, but also to mitigate any concerns from health security side of things. And several studies looking at the access to vaccines as having knock-on effects for health security benefits. Now that's a pretty obvious one, but there was considerable literature saying that, having reliable access to vaccines will have knock-on health effects. This raises a couple interesting questions, and I'll just go through them quickly, and then we can get to it in the Q&A. We think that this focus on the global south ignores health risks from high income settings. And I'm thinking of the variants under COVID-19, but certainly AMR. Limited health systems for health security research tackling syndemics. Are there multiple risks? Less on social or economic or environmental determinants and upstream determinants. And we think that that's a shortcoming. Undervalued link between health systems and health security. Although we did find these case examples and there was literature available, on the whole, the link is undervalued. This is an area for improved evidence and research. There was no research, not a single piece of research that used the WHO system building blocks as a heuristic for health security. We found individual interventions within sort of subcomponents of building blocks, but never as a sort of methodological tool to try to get your head around that relationship between the two concepts. We did find case studies, like I said, that did help think about system readiness, resilience, and security. But again, those were only some case studies and not enough. There was a tendency to focus on national security versus human security. There was a tendency to focus on surveillance and emergency response measures. There was a prioritization of health security over health systems, generally in the literature. And by doing all this, we think we have identified a research gap which required improved evidence. Now, just to be clear, and maybe to sort of preempt some of the questions, we're not claiming to say anything too novel here. A lot of us who have studied this have these intuitions or have some idea that these were problems within the literature, both on health systems and in health security. But what we think we've done is systematically kind of outline this in a way that shows this is a problem beyond our sort of light touch literature reviews or intuitions about this. Thank you very much for listening.
We've got some questions coming in. They're not taking any prisoners, so I'll start with the first. Straight away, I think the starting point for conceptualization might confuse the way forward. The first slide projects health systems and health security as two distinct platforms. And we go on to say how health security is linked to health systems. Health security is being conceptualized as a goal for health systems the same way as other goals have been. Such as improved health responsiveness and financial protection. Health systems have been designed to advance the latter three goals by advancing UHC. What will be needed to shape health systems to advance not only UHC, but health security? Dr. Mataria is suggesting that maybe this advancement of health security as a correlate of stronger health systems is a subordinate goal of health system strengthening, rather than something as important as strengthening the health system. So how would you respond to that?
If I understand the question right, that health security should be subordinate to health systems and health system strengthening, that health security is actually a result of strengthened health systems. And I think that that's what the framework is proposing. And I very much agree with that personally. And in my research for the last 25 years has been arguing that for a very long time, that health security in the literature is a very sort of 1980s version of security that I think misses the point, which is an ounce of prevention is worth a pound of cure. And that's how you sort of find your prevention and your health security. However, that's not what we found in the literature. The literature tended to focus on one or the other more than the other. And the health security literature in particular tended to focus on the whole that health security was the primary of the higher level of politics, and that health systems was a routine, everyday sort of politics. We think that that, again, undermines the previous concept that I outlined, that an ounce of prevention is worth a pound of cure. So I think I agree with the question. So we're trying to break that down. We were trying to highlight that this poses problems for us because we need to reconceptualize health security, full stop. And that this points to the need for the framework, I think would be our conclusion, that the framework is addressing this gap.
Are we clear about what the ultimate goals and intermediary objectives of health systems for health security are? For universal health coverage, these are agreed upon somehow. Ultimate goals are equity in access, financial protection, and quality, while intermediary objectives are efficiency, equity, and transparency.
I think I agree with this. I think the conceptualization of health security is weak. It's not as robust as other concepts we have in health. And therefore, part of the objective of this framework is to help clarify that relationship between health systems and health security, that it is an underspecified relationship at the moment. I've been highly critical my whole career of the term health security. And in fact, when Nirmal and his team contacted me, I thought, oh boy, I don't really like the term full stop. I've tried to avoid using it because it had sort of a certain language, countermeasures and sort of this militarized speak that went with health security. But then when I read the framework, I thought, no, this is exactly the right thing to do, because we need to reappropriate the concept. And we need to do it in such a way that it's more conceptually robust. And I think this framework is starting to move towards that by including things like common goods for health, by including a focus on primary healthcare, by including various benchmarks and capacities that speak way beyond sort of health security in the short term, the exceptional side of things, and much, much more towards sort of population health. And I'll just make this one point. I mean, COVID-19 exposed that if you have bad or poor underwriting population health, you're going to see stronger effects of the translation from SARS-CoV-2 to COVID-19, from virus to disease. You are going to see worse conditions. And if your baseline population health is struggling and with certain comorbidities, you're going to see this result. So for me, the health security is about having very healthy populations, primary care level, et cetera, et cetera. And I think that this framework is starting to move in that direction, but it's a work in progress. And these are entrenched conceptual ideas that take a while to reconceptualize. It's just the way it goes. And this is the start of it. Jessica, did you want to come in?
I wanted just to go on your side that we really need this comprehensive framework that finally put the two concepts and all the concepts associated to this together in order to have the same objectives and not to be balanced on one side or the other. You really need to integrate, and I think both things together.
I just want to add a couple of points here. And one of the slides, when I presented about components of health system for health security, we highlighted goals of this framework. And because this framework is and health system for health security is not another vertical things. It's within that health system where we need to ensure that we have a functions and capacity in place so that overall requirement for health security is improved. What does that mean? Is from prevention, detection to respond and even mitigate. And when the event like pandemic, then we also need to recover also. So one thing is, in addition to the overall goal of health system, this framework is also envisioning that it will ensure or complement to those overall goal of social and financial protection, improve efficiency, healthier population, and responsiveness. But in addition to that, we, as part of the health security, we need to have improved health security, the capacity to prevent, detect, and response, as well as the resilient system, because it's not only essential health services, but at the same time, if country suffer another outbreak of cholera or measles in one of these highly impacted COVID-19 countries, then what could be the result? So this is where we need that goal also to address. And this is what we will be collectively address and bring into the framework.
It sounds as if health security is becoming a vertical program similar to health system strengthening. This is unlikely to succeed as pandemics require pan-system and government responses. So verticalization by the WHO and the USG is the wrong approach. Tough, but I think would be the elephant in the room for a lot of people.
I think that health security has traditionally been siloed as another vertical. It usually comes in late as a response, and it usually, like our literature review suggests, doesn't talk about prevention or preparedness. So it's really something that comes in exceptional circumstances, potentially even with the use of military or other things for countermeasures for disease. I think that has been the trend, but that's what cannot be the trend. So part of what the framework is trying to do with a multi-sectorial approach and involved with it, with a much better focus on preparedness and prevention, is to do exactly that, is to break the vertical silos that have underwritten health security for so long. Now, why health security then is the question. Why even use the term at all if it's a bit of a loaded gun? I think, there's a practical reason to do so. One is COVID-19 has put health security front and center on the agenda, and people want answers. And it's cost nearly $20 trillion so far in lost GDP and rescue packages and everything else. You know, if we're going to invest money on health, and there's this big focus on health security, it's important to show that to reconceptualizing health security for the long term, and to get that kind of political will and backing involved with it. So what health security does do is kind of promote that, in the sense that it's on everyone's mind and it's high on the political agenda. So I think there is some mileage in it, but I also am acutely aware that it could just go back to kind of business as usual. We saw that in 2015 at the G7, they said Ebola, never again. We're going to put this global security agreement together, and not everyone signed up to it, and it's underfunded, and they're not doing much on AMR. It could go all that route, or it could not. Maybe COVID-19 is the catalyst for real change and for linking these concepts up. And if you don't give it a shot, then you can't complain that nothing was done. Here's the alternative, here are the arguments for the alternative, and then you move from there.
So no, thanks very much. And I would like to just build on what Professor Brown has talked about regarding this, catalyst that we are trying to use here in COVID. And I think there were a few things that we see in COVID in terms of being able to surge to meet the demands of emergency, being adaptable and flexible enough to move resources to areas of greatest need, as well as being able to mitigate the impact on essential health services. And that's where we found ourselves talking more to the health systems colleagues on the other side of WHO. And I think one of the things that we discovered in our conversations is that while everyone is of the public health community, in quotations, the language that is being used at the health security level or discussions or fora is quite different sometimes from the way that health systems people look at things. And so this is really an attempt to bring together both sides. And perhaps another way of looking at it is that some of you may know that we have these national action plans for health security, right? So these are health security plans that were developed to close some of the critical gaps in preparedness, prevention, detection, and response. But if we don't integrate them with the national health strategies, sector strategies, for example, that really drills down into the building blocks of manpower, of essential medicines, etc., we'll never get the investments required, and we'll never be able to fully realize preparedness and health security. And we're learning that from COVID. For a long time, we've been saying that there's not enough investments in the national action plans for health security. But COVID is proving that you can't separate the two. So I think we are trying to break those silos. It's not going to be easy. And indeed, there's always this risk that it becomes another pillar of its own or another work stream of its own. But I think within WHO, and this not just needs to happen within WHO, but at every level of health system in every government, national down to the local level, if there are departments that have been operating in silos, they need to come together and see that the fundamental change is that the two agendas of universal health coverage as well as of health security now need to be brought together through the strengthening of health systems for health security and UHC. Back to you, Dr. Williams.
What are the critical enablers to better link health systems to health security in low and middle income countries?
Big question, but I think what we spoke here, it's already to have the same goals and to change your goals. I mean, if you how you think your system to make him stronger every day, as we said, every day and during emergency. So probably we also need to redesign and to conceptualize the focus and the objectives of where we want to go, and we cannot just overall objectives.
The objectives are key. I mean, you need a compass, you need a bearing, you need to move towards something. They may not be realizable, but you need to have an idea of where you want to go. The key enabler for me, I think, if we're going to look, let's just take a building blocks perspective, is governance and leadership. I think that that's the key enabler in all of this, because financing follows governance and leadership. Workforce and access and the other building blocks follow the financing, which follows the governance and leadership. So the key to getting this off the ground is, I think, getting policymakers, getting the general public, getting practitioners, getting people who are on the front line post-COVID and who are upset about it, people who have their lives massively disrupted because of COVID and are upset about it. And that includes just about everybody. So it's not just low-income countries or middle-income countries, it's high-income countries, to put pressure on governance and leadership in a way that takes these things seriously. Now, there's a clear economic argument as far as I'm concerned. $20 trillion is a lot of money to lose in about a 16-month period. What would meaningful implementation of this framework at the national, regional, and global level, like taken seriously, what would have that cost? And what would have been the return on investment if it was in place prior to COVID-19? And that's, I think, the enabler, making that kind of sell to leadership and governance and having them then take that seriously, that health is no longer a line item of expense, it is an investment. That investment pays dividends in two forms. One for acute health emergencies, obviously important, must be done, but also in having healthier societies and populations, which has all sorts of positive long-term knock-on effects. For me, always when I think about the building blocks, that seems to be the key building blocks. You can have all sorts of other technical efficiencies built into the system, and you can have resources here and resources there, but if there's not governance and leadership, it's not going to deliver high optimal outcomes.
Often silos are created due to funding stream. How will donors be brought into this discussion and planning process to ensure that we have a more holistic health systems and health security approach?
I think that today we have like a paradigm shift. There is a lot of concern for comprehensive approaches, even by donors. So probably this is, and COVID will be the driver of this change. I think that donors are changing to define their priorities and implement projects. So probably operationally, the operationalization is still a big challenge, but there is at least a big change towards more comprehensive approaches and taking account different sector and different. So also, yeah, I hope there will be a move to reduce the silos between health system and health security priorities.
Oh, and I just want to say that I also think it's the way that these things are financed that tends to create the silos, largely due to accountability mechanisms where large funders want to see how the money is being spent and what returns they're getting on that money. And by doing so, they set up very tight programs with targets and indicators, and they end up just looking at one area or one form of intervention, say child and maternal health or whatever. And that then creates a sort of a silo, in some cases a silo of excellence, and sometimes a silo that doesn't actually make much difference at all, but still receives a large amount of funding. So again, this goes back to the governance and the leadership. There's no guarantee here. So, I get this question all the time. How are you going to make sure X doesn't take place? I alone cannot make sure of that. But what I can do is expose the conceptual links in such a way as to paint this problem as something that is a problem that needs to be rectified, and then find out solutions for doing that. And I think funding is one major way that we'll have to look at that. So once we get individuals on board with the framework, decisions about funding and implementation and about national level implementation and global buy-in will all have to take place. And again, I think this is going to have to be something for Nirmal to answer, because he's much more on the spear point on this than I am. I'm the backroom research guy.
Is the WHO, through its regional offices, having a plan of developing guidelines for recommending ministries for having health systems for health security framework?
3 points. So first, definitely this resource thing, and this is why we have a tomorrow session with partners and others also, and we will be reaching out and exploring other avenues for resources. And at the same time, because of the COVID-19, even the development aids will be limited because there's a recession, there is a $20 trillion loss. And this is where we need some innovative financing mechanism. We should put it in place. And then the second part is, we have discussed and we have shared this framework with our regional colleagues, and many of regional colleagues work with their health system colleagues in the regional office also to come up at this stage. And this is I mentioned in my presentation also, this is our strength, WHO's competitive advantage of having a regional office who understand regional context and the countries also. And this is why it is a joint effort of all the WHO team as a one WHO. And the second, and I also noticed there is a question, is there a presentation from our talking from health system colleagues also? We have a colleague speaking in an afternoon session from health system on health information with some country example also, and then our colleague will be chairing some session as well. So when we are moving forward, definitely we need to identify key areas to support countries and how to move forward. And this is where, framework is overarching. What is important is at the ground, what we are going to implement. It's easy to say, okay, this is the framework, you use it. No, but what we are coming up with in addition to the framework, with the list of actions, those key actions. And we are discussing with other department in our readiness department and other disease specific team also to come up with those 3 benchmark actions. Like, for instance, we already have a disease specific, for syndromic specific few waterborne disease, like taking the cholera benchmark actions. So what country needs to do for the cholera related event, there's a list of benchmark action. And similar thing, the first time we are coming, what are those health system elements that should be in place? So I'll be and we'll be repeating these things because there are certain prerequisite elements that needs to be in place. You cannot build strengthen IPC capacity during the emergency. It has to be in place. WASH facilities should be in place. People should be trained. Health workers have an enabling environment with all the logistics required. That is the role of health system. And this is where this is not the vertical things. I think one of the Garrett nicely highlighted earlier that this is the way where we are integrating, bringing together. And for us, this whatever the elements of health security as part of the health system is already a part of health system. So it's not the totally new thing. We are not going to create any new thing because we will be using, country will be using the same health system the way COVID-19 we are using to respond to the event.
Thanks, everyone. Thanks for coming and saving me, Nirmal. The reason why we're putting on this event and why we've had such a long Q&A session is because we want to hear feedback from people. We want to engage in a deliberation. So we will be tracking the questions. We will be getting back to people in terms of when we do build a network, you will receive another email from us in a few weeks saying, would you like to be part of a network? Because we want this dialogue to happen. Skepticism is not always bad, it can be a driver for change if it's done productively and with an idea that we all want improvement. After lunch is going to be interesting. We have a lot of country speakers who are going to talk about lessons learned from COVID-19, and they're done by building blocks. So we will see the links between health systems and health security in terms of those building blocks and how certain countries performed and responded to COVID-19 and what that says about that relationship. And I think I'm really very much looking forward to that. So please come back at. Good afternoon, good evening, or good morning, depending where you are in the world. Welcome back to the Health Systems for Health Security workshop between the University Leeds and the World Health Organization. This session is COVID-19 lessons from case country settings, and this is the session I've been most excited about for this workshop because we're going to hear from various case countries about how they've responded in relation to a particular building block to COVID-19 and what kind of lessons maybe can be learned about health system strengthening for health security. This session will be chaired by Dr. Kasum Jallo and will be moderated by Dr. Rebecca King. Dr. Jallo is from the Data Evidence and Knowledge Unit. He is the head of that unit at the WHO. And Rebecca King is Director of Nuffield Center for International Health and Development at the University of Leeds and one of my colleagues. So enough for me. I hand it over to you. Thank you very much.
Thank you very, very much, Dr. Brown. And let me join you to say good morning, good afternoon, good evening, depending on where you are. A warm welcome to everyone to this afternoon session. So earlier today, we heard from Prof. Brown and Dr. Martini about the current research on health system for health security. This afternoon, we will hear more about what is happening on the ground at the national level. So we have a rich panel composed of high-level and highly qualified colleagues at national level who will give us the pulse on the ground, covering various building blocks or capacities such as the governance, the leadership, the finance, health workforce, service delivery, essential medicine, health information, and multi-sectoral coordination, and animal health. So during this session, each speaker will share experience, best practices, and lessons learned from his or her own country, and how strengthening of health system capacity in one of the 6 building blocks of the health system and other sectors contributed to the management of the pandemic.
Good day and good evening to colleagues. So COVID-19 has had a deep and devastating impact on every country, and Singapore has not been spared. Now, the devastation brought by COVID-19 was completely unanticipated by many who have never experienced similar crises before. While no country can claim to have been fully prepared for COVID-19, Singapore was arguably better placed than some. Our painful experience of SARS in 2003 taught us the importance of investing in pandemic preparedness. Now, there are many important lessons to learn and opportunities to seize if we want to emerge stronger from COVID-19. So let me share 3 of them. First, global leadership. The WHO has a central role to play as the UN agency, as the sole UN agency with the mandate to act as the directing and coordinating authority on international health work. But unfortunately, like many other multilateral institutions, the WHO has faced significant hurdles fulfilling its mandate. It's not been able to operate as independently as it needs to be, and it also needs to be funded adequately. It is in member states' interest that the WHO has the necessary resources to carry out its mandate in global health, because a healthier world is a safer world for all of us. Second, global partnership. Established by the WHO and other global health actors, the Access to COVID-19 Tools Accelerator, or ACT-A, has supported the largest and fastest global effort against the disease in history. Now, notably, the COVAX facility has brought together multiple stakeholders to support fair and equitable access to vaccines. Now, so far, they have shipped close to 70 million COVID-19 vaccines to 124 participants all across all continents. Now, we have also seen an unprecedented level of information sharing and cooperation in science and technology. One example would be the sharing of genomic sequences of COVID-19 through GISIT, which is a global science initiative to monitor the emergence of new strains of the virus. Now, GISIT has since received more than 1.6 million genomic sequences from over 140 countries. Now, lastly, the last point I wanted to share would be on national or local leadership. The government must take the lead. Now, Singapore, we established the Multi-Ministry Task Force on 22nd of January 2020 last year to direct national whole of government response to the outbreak and to coordinate across ministries and all affected sectors. Now, we did this even before we had our first confirmed case. But yet at the same time, we are very aware that the fight against COVID-19 cannot and will not be able to be achieved by the government alone. We have learned the importance of mobilizing the entire population to tackle the crisis as a whole of society. Now, Singapore's success in containing the outbreak so far has been in part due to the collective efforts of the society to abide by the stringent public health and safe management measures. Now, the government's track record in responding to past crises such as SARS have laid the foundations for Singaporeans to remain confident in the country's ability to manage the outbreak. But nonetheless, trust in government is not a given, nor is it perpetual without continual efforts. We must not take it for granted. I look forward to a fruitful dialogue and exchange of minds for the rest of the session. Thank you.
Thank you very much, and pleased to be here. And I'll just share a couple of issues regarding the financial issues related to the COVID pandemic actions in Finland. And I think that this is kind of a also global and shared issue, because this has been a global financial crisis, and it has affected, of course, every country's financial situation, and also it has had effects on how to go on with the measures to fight the pandemic in every country. In certain sense, Finland has been doing quite well in comparison to, for example, other European countries in financial aspect, as well as in the fight of the pandemic, because we have had the lowest amount of cases per capita in the Europe at the moment. And of course, also our financial crisis has been smaller than in some of the other European countries, and also this has had a huge global effect on the economy. What we have learned in Finland, that our experience is that the kind of good management of crisis and preventive measures to avoid unnecessary spread of the virus, it is a way of fighting against the virus. It is good management of public finance and it's a good fiscal policy matter also. If the pandemic requires very strong measures, it will have a strong effect on also the country's economy, and this will have effects also that will come against the kind of the country's work after the pandemic has ceased, and of course it will have effects on the national economy as well as the global economy. What we learned is that we have been working with the community of citizens with quite a good trust in authorities and trust in science. So it has helped us to maintain decent amount of measures, because we haven't had this kind of very strong and long-standing lockdown measures in Finland. Of course, we have had very strong measures, but comparison to other countries, we have managed in some sense with more medium-term measures, and we have managed to keep the society more or less open throughout the pandemic from the beginning of 2020. And this has, in certain sense, also affected our country's economy. So we haven't had very steep downgrade on the economy, but of course we are trying to kind of work our way back also in the economic sense. But if we look at what we did in terms of health system, the government of Finland quite early on made a decision that the government is committed to reimbursing all costs to local authorities, municipalities, hospital districts, for example, from the testing of COVID-19 virus, protective equipment that the local authorities need to purchase, and also the additional costs that will affect the social and healthcare system. So the government made quite a strict decision on covering all the costs that the pandemic will give to the local authorities. And this has, in a sense, provided the local health, social and healthcare authorities the possibility to rely on the situation that they don't need to worry about the financial crisis that might come about while fighting the pandemic. And also there hasn't been any lack of protective equipment in Finland. And this has been, I think, one of the key issues that we have had in Finland that has helped us in the economic sense and also in maintaining the kind of the workability and ability to maintain a good healthcare system in Finland. Thank you.
Hello, everyone. First, I would like to reiterate that the pandemic preparedness needs strong capacity to prevent, detect, and respond. These are complex activities that need multi-sectoral and multidisciplinary collaboration, not just the health sector, as Dr. Kendall mentioned in the earlier section. And for health sector, we need strong capacity for early detection, outbreak investigation, disease control, as well as treating the patient. Thailand started to prepare our health system capacity since 4 decades ago. In the early of 1980, Thailand initiated a major health system investment. 3 main areas that we achieved included: first, we invested extensively on rural health infrastructure, full geographical coverage of health services, health center in all sub-districts, district hospital in all districts, provincial or regional hospital in all provinces. This fosters equitable access by all. And second, domestic training of and retention policy of health workforce at primary, secondary, and tertiary care. This fosters well-functioning health services. And third, gradual extensions of insurance coverage to targeted population until universal health coverage was achieved in 2002. This fosters financial risk protection with access of essential health services for all. Responding to COVID-19 is a good example that the USC paid for testing, treatment, and the rolling out of vaccine for all. And focusing on the health workers, adequate number of committed health workers are the wheel that make health system function. In 1980, we start capacity building program on the outbreak investigation, the field epidemiology training program, or FETPV, following the Epidemic Intelligence Service, or EIS, of the US CDC. Currently, we have almost 200 trained field epidemiologists in almost every province in Thailand. Starting in 2004, we established more than 100 surveillance and rapid response team, or SRRT, through capacity building on existing healthcare workers in the province and district. In 2002, the FETPV was expanded to an international program, and later we established the FETPV, or Field Epidemiology Training Program for Veterinarians based on One Health approach, and this has proven to be effectively in the containment of H5N1 in 2004. And with the primary healthcare movement, we also trained and maintained more than 1 million village health volunteers, or VHV, who are active in every village to support the activity to detect and control the outbreak in close collaboration with the local health workers. They have addressed numerous outbreaks such as pandemic flu, avian influenza. And during the COVID-19, the SRRTs serve as a major frontline force and play a major role in contact tracing and active case finding. They also communicate and educate the community on the situations of COVID-19, misinformation, and encouraging vaccination by door-to-door approach. And this story is only a small part of the whole health system in Thailand. There are several health professionals who are the main comrades, in particular the main power in the health services. We believe that what we have today is a product of past investment, and COVID-19 has already proved that health is security. The key success to fight with new threats is the visionary leaders and continued investment in health from generation to generation, and dedication and spirit of all health workers for the benefit of mankind. And COVID-19 warns us that our current system is not sufficiently agile and resilient to the new threats. And this is a big challenge to the global community to collectively prepare and support one another to get through this crisis together. And how shall we prepare for the future? Thank you very much.
Thank you very much. Yes, I mean, it's unfortunate my video cannot be on because of my low bandwidth. So kindly pardon me for that. Yeah, so on the service delivery, Ghana had its first case of COVID-19, or even actually 2 cases on the 12th March 2021. A national response plan for the COVID-19 was developed. And the national response plan had 2 components that were really service delivery. One was slow down and manage community spread of COVID-19. And then 2 was provide adequate medical care for COVID-19 cases. So with regards to the slowing down and managing community spread, the surveillance system was enhanced. We deployed all our community structures within the primary healthcare setup to trace, as contact tracers. So we have our community health officers within the various communities doing the contact tracing of every case that was identified. And then these were also tested. Those who were found positive were, from the testing, snowballing contact tracing was done and isolation was done. So within that context of service delivery, for the surveillance was really enhanced. And then the other objective within the national plan was providing adequate medical care for COVID-19 cases. So a national team, a guidance document on care was developed, and cases were mainly managed at home. If they were asymptomatic, a majority of them were asymptomatic. So where the home situation was okay, they were managed at home and visited occasionally by the treatment teams. And in facilities where the disease severity was very high, yes. And in most of the cases, the patients were really assessed so that if the patients warrant home management, then it's given the home environment. Yes, some facilities like beds, etc., were obtained from the private sector. And then the faith-based sector, they also, in the high intensity areas of Accra and Kumasi, these private sector and faith-based supported by providing beds. And then also to increase the number of beds to manage critically ill patients, the private sector, that is the corporate sector in Ghana, was mobilized. And they were able to build a 100-bed capacity infectious disease control that provided a lot of the beds for the critically ill patients. In terms of laboratory support, there was massive expansion of testing facilities using the existing gene experts. We adapted a lot of the gene experts that we were using for tuberculosis testing to test for DNA PCR for COVID-19. And then we also procured some DNA PCR equipment that we deployed in our research centers. Ghana Health Service had 3 research centers. So we equipped them also to do the DNA PCR testing in order to reduce the turnaround time in testing. Then we realized that the other services, the essential services, was also going down, especially during the lockdown. So quickly, the Director General appointed the Deputy Director General to oversee ensuring essential service continuity. So during that period, a rapid assessment, a phone assessment was done to find out some of the reasons leading to the deterioration or the decline in delivery of essential services. And one of the key things were the PPEs that needed to be provided. And the government engaged the private sector industries to modify some of their operations to start manufacturing PPEs, which were distributed to the health centers. And then we continuously engage the regions on the targets of the various services. We use the Zoom meetings to engage the region. The regions also engage the district so that we kept track of the other services. And then also we develop a guidance document that will enable health workers to provide essential services in a safe environment for themselves and the other staff. And we use the virtual media to train and orientate the health workers on these. And when you look at the data, we started recovering remarkably in offering the essential services. So as we were dealing with the COVID-19, essential services continue to be done. We did yellow fever vaccination, we did polio mass vaccination, we did the seasonal malaria chemoprophylaxis at the same time. And in the first time, we recorded the lowest maternal mortality, that we've ever had. And it was because of the benefit that we've got from training on infection prevention and training on the critically ill patient. The ripple effect was translated also into the maternal health side. So more or less, this is how service delivery with regards to COVID and then ensuring essential services also were managed in Ghana during the COVID period. Over. Thank you.
Thank you very much, distinguished panelists. I'm standing in for my boss, Dr. Adebimpe Adebi MNI. We've learned some lessons in the course of the response for the COVID-19 pandemic in Nigeria. One of the lessons that we've learned is that there need to be a very strong leadership in place. As a country, that was provided by the Ministry of Health, which led the health sector response for the COVID-19 response in the country. The Department of Hospital Services is the department that statutorily are responsible for the case management component of the COVID-19 response. And the department, in conjunction with the isolation and treatment centers in the country, about 173 and about 56 federal tertiary health institutions have been able to successfully manage close to slightly over 300,000 cases and manage also a reduced infection in centers. Another aspect of the response, the pandemic has also brought in some upgrade of the structural upgrade in Nigeria. As we speak, all our federal tertiary health institutions in the country, teaching hospitals or federal medical centers have been designated to have at least one PCR lab, and at the same time also have an isolation center. So in total, we've improved about 56 isolation treatment centers in each of the federal tertiary health institutions, well-equipped capacities and ability to manage both mild, moderate, and severe cases. The country has also made progress in bringing in the private sectors and other sectors, development partners like bilateral organizations and international organizations, WHO, UNICEF, and others to work together. The private component of the response, the COVID, were mobilized, and they have also been able to support healthcare workers and also support isolation and treatment centers with personal protective equipment and drugs for patients, hospital equipment. Another aspect that has led to improvement in the health sector is the issue of capacity building and training of healthcare workers. Conjunction with partners, we've been able to train intensivists. We understand that 5% of the cases are usually result in severe and might require intensive care admission. To build the capacity of health workers to manage these severe cases, there was a consensus that was agreed by stakeholders that a specialized training will be done for nurses, general physicians, physiotherapists to upgrade their knowledge to handle severe cases by training of intensivists. And this is done using a regional cascade model where the nominated participants aggregate in a particular center where there are high volume ICU cases, and then they are lectured for some times, and after the lecture, they will now man the ICU for a hands-on experience. And after that, they can now become master trainers after 2 weeks, and they will now come back to their centers and step down the training for others. Some other aspect that the country has made progress is we've improved the surveillance system by deploying softwares for monitoring. Some have been deployed. We've also improved quality of care. We've also seen results in the case fatality rate for the country, which is about 1.4. and one of the least globally. Thank you for listening. I will be available for any questions or clarifications. Thank you.
Thank you very much for giving me the opportunity to represent India. So in the COVID-19 situation, we initially thought that the availability of drugs would be most important. That was our first phase that we thought we should work upon. And then simultaneously, we were also focusing on the need for vaccines, COVID-19 vaccines. So initially, we did quite well in the first phase, first wave of the COVID-19. We managed with all the shortages, initial shortages of PPE kits and some essential drugs. There was also at some point of time a shortage of oxygen, but we managed that in 2020. This time, in the last 2 months, it hit us very hard. There were issues. We did not realize the scale of that. Health security in this situation, we did not manage it quite well, anticipate how bad it would be. So this is one of the lessons that we have learned. With relation to the vaccines, we were on track on the development part, the production part, not just for protecting our own people, but also citizens of other countries. The COVAX facility was being an integral part of this whole system, and we were contributing to that on COVID-19 vaccine equity and security globally. When we started our vaccination program, we started it with the health workers because we realized that if they are not there to run the hospitals and the health centers, we will not be able to provide treatment to the patients. So the first priority was given to the health workers, and later on the frontline workers and the above 60 age group. So currently, now every adult is eligible to get vaccinated. One of the things that we realized was that we are using a software to get the allotments for appointments, the slots for appointments to persons who wish to get vaccinated. And we were also cognizant of the fact that there are many in India who have no smartphones or access to internet services or unable to navigate online portals to manage transactions related to banks or railway bookings. So for these people, we early on had special community service centers in rural areas to help such persons get access to the appointments. This also gave us an opportunity to strengthen our existing cold chain system within the immunization program. And it is also important that during all of this, we were able to continue with routine immunization services and other preventive health services. We believe that the challenge provided by COVID-19 will work as an opportunity to strengthen our health services and prepare for future challenges like this, disasters, anticipated or unanticipated. Now we have a massive push in place to overhaul the primary health centers, especially in rural areas, because it is anticipated that the third wave is going to hit our rural areas badly. So we are already working on that right now. Linkages of these primary health centers to higher centers are also being strengthened so that the severe cases can be managed there. The production of essential services is also being ramped up, learning from what we faced very recently. Oxygen supply channels are being streamlined. The dependency of hospitals on supply of oxygen using cylinders, we are trying to reduce that. And most hospitals have been asked to expand oxygen storage capacity. We have excess stock in place to manage the demand for oxygens when it comes. Adequate stock of essential services are also being created so that we are ready for it. We are at the same time very thankful to the international community who stood by us and supported us with medical supplies, essential medical supplies and equipment when we needed them the most the last 2 months. We hope that no country faces such a crisis, but if it does, we are sure that the world will come together again to help that nation. So thank you once again for giving us the opportunity.
Thank you very much. I really thank the University of Leeds and WHO for organizing such an important workshop and giving the opportunity for the countries to share the lesson learned. I will briefly share the existing information system within the country and then how it was used during the COVID-19 pandemics and what new intervention were also introduced. So in Afghanistan, we have a routine health information system, which is based on the content of the 2 service delivery packages we have. We have a basic package of health services for primary healthcare, and we also have essential package of hospital services. And based on the content of these 2 packages, National Unified Health and Management Information System was developed, and it is being implemented across the country. And in that system, the reporting starts from the grassroots level, from the community, where the community health workers are stationed at the health post, and they provide monthly reports to the health facility, and the health facility then compile all the reports from the grassroots level, from all the health posts in their catchment area, and they submit along with their own reports to the provincial level. till provincial level, all the reporting is paper-based. From provincial level to the national level, reporting is digitalized, electronic. From the provincial level, all the reports are feed into DHIS2 platforms. The health facilities are submitting an integrated monthly activity report, which is a kind of snapshot from all the services provided in that health facility. And then we have, based on the donor requirements or the Ministry of Public Health different program requirements, then we have a modular approach where the detailed reporting for EPI, for malaria, for tuberculosis, TB information system, those models are also integrated in DHIS2 platforms. In parallel, we have these reports are on monthly basis, from submitted from the grassroots, from provinces to the national level. And then we have a national disease surveillance system, which is being supported by the WHO since 2006. They're collecting the data on incidence, morbidity, and mortality of the 16 priority disease on weekly basis. And the data of all other infection disease, if it happens, if it happened as an epidemic or outbreak. But during this pandemic, we observed that the coverage of this surveillance system is very limited. It does not cover all the country. There was an assumption that many cases would have been missed through this existing reporting system. Based on availability of additional funding, additional human resources were deployed at the country level and the structure of rapid response teams in order to enhance the reporting. And then a COVID-19 module of DHIS Academy in Oslo University was also adopted. One of the, maybe the first country to adopt that COVID-19 module, which also enhanced the reporting from the point of entries, contact tracing, also from the COVID-19 lab reporting was also enhanced. And then COVID-19 dashboard was developed in the DHIS2, which is accessible for everyone who want to use the data. In a country like Afghanistan, which is very much donor dependent, the government contribution is very much limited for the health service delivery. The sustainability of all this system is an issue. Thank you very much.
Let me first start by thanking Dr. Nirmal for organizing this important meeting. And I think from a regional perspective, this is really timely in a way that we're all moving in how we can further enhance health security as part of the overall health system strengthening. And I guess this is really timely in a way that we have a lot of lessons learned that we have all gathered from how countries have been responding to COVID. It's pretty much important that we share these lessons learned from different perspectives and to see how this can be further materialized on the ground. From the regional perspective, maybe a little bit before talking about how multi-sectoral coordination worked during the pandemic. Before the pandemic and exactly at the time of Ebola, we all learned that there has been a number of multi-sectoral coordination mechanisms existing in countries. However, those mechanisms were not really functioning. And therefore, one of the main advantages of the joint external evaluation was really to look into the functionality of different mechanisms that claim to exist on the ground. And therefore, when the majority of our countries in the region have managed to develop national action plans for health security, enhancing multi-sectoral coordination was really one main component or one main element of these plans. Lucky us in a way that we have those plans for almost all countries in the region. But one of the main disadvantages or limitations that we have seen is that those plans were not financed. In a different word, domestic finance were not allocated to implement the national action plans for health security. Of course, this is not a blanket conclusion for all the countries. We know that there has been a varied level of implementation, but the point is, in a big number of countries, allocation of resources was a limitation to implement the plans and to further enhance the multi-sectoral coordination. When the pandemic started, the majority of the countries have declared the emergency status. And this came immediately after labeling the public health emergency of international concern as a pandemic. And therefore, the pandemic was considered as a national emergency, and additional layers of multi-sector coordination were established. Those layers have been managed by the highest level in each country, either by the president or by the king or the prime minister. And we know that for these multi-sectoral coordination mechanisms, there were a representation from all sectors. Of course, the main advice was supposed to be taken by the health sector. But at the same time, we know that all sectors were involved in this multi-sectoral coordination mechanism. Additional layers of technical coordination mechanisms were also established to look into some technical issues, whether surveillance or lab testing or management, etc. I think the most important part when we look into the multi-sectoral coordination mechanism is that we know that the incident management structure exists. We were expecting that the health sector to take the lead or to be the incident manager. The fact that this is a health emergency, but the fact that this emergency was declared as a national threat to health security, the health sector was not mostly leading the response to this pandemic. It's true that the health sector was taking the lead in issues related to testing or surveillance, but we know that the health sector was not really taking the lead when it comes to travel-related measures or trade measures or even measures related to social distancing, such as the lockdowns, curfews. Just to conclude, this really somehow highlights a lot of lessons learned. One is that regardless of the number of coordination mechanisms exist in countries, it's very important that we find a link between those coordination mechanisms. The fact that we have a pandemic, that does not mean that in each emergency we need to establish another layer of coordination mechanism. Coordination mechanisms should be in place. It's important that we build on these mechanisms to see how they are part of the overall response to any emergency. And the second point that we learned is that it's very important for any coordination mechanism to have a legal support or a legal ground, because this will give it a legitimacy on the decisions that they're making and how those decisions can be implemented or further materialize on the ground. It's also very important to understand the roles and responsibilities for the different sectors. We know that a health sector has been playing a major role, but at the same time, we know that the health sector was not really taking the lead in some great decisions. And this somehow, I wouldn't say create confusion, but it's very important to streamline decisions that should be built or taken based on science, rather than having other factors affecting the decision-making process. And therefore, clarifying the roles and responsibilities and who is the incident manager in this emergency situation is very important. We know also that the health cluster coordination mechanism has been in the countries that are going under emergencies. And these cluster coordination mechanisms also has been playing a great role in terms of the response. But regardless of their presence, also in the emergency countries, additional layer of coordination mechanism were established. And this also takes me to the same point, is that no matter how many coordination mechanisms we have in the country, it's very important that we have all of them speak to each other and come out with alignment process in terms of the decision making. And also additional lesson that we learned is that particularly for the emergency countries and where we have a cluster coordination mechanisms, the concept of humanitarian development peace nexus was not really materialized. In other words, we know that when it comes to the response, it was mostly focusing on short-term response operations, and it does not really look into a longer-term perspective, whether from a health system perspective or from a development perspective, if we're talking about humanitarian-related situations. And this really highlights how important is with any coordination mechanism. It's very important that we're not only focusing on how we're going to respond to any emergency. It's very important that we look into longer-term perspective, and particularly for the emergency countries where we want to always to bring the development and peace component rather than only continue to focusing on the humanitarian component.
I would ask you to conclude,
and then my
please.
last word. Yes, my last word is that in the different coordination mechanisms that we have seen so far, community engagement was pretty much missing. And we have all learned that community engagement is very important in order to make sure that there is a proper response to any emergency. And for this, I would like to conclude by saying that in any coordination mechanism, it's very important that we bring the community engagement component in order to make sure that we have all the society presented or represented in the different coordination structures in any country. And thank you so much.
Thank you. Merci beaucoup, Dr. Kassoum Diallo. My talk is focused on the experience and lesson learned in strengthening capacities in the animal, human, and environment health sectors for better health security based on the One Health approach. If I can give a brief definition or to rhythm the One Health concept, I should say that it's about collaborating, communicating, and coordinating between people who protect human, animal, and environment health in aim to achieve the best outcomes, mainly health security for people, animal, plants, and our environment. The current COVID-19 pandemic has once again raised the One Health to a global celebrity status. The COVID-19 crisis has demonstrated how human health, the well-being of animal, and global health must not be viewed in isolation, and that depend to a large extent on the way in which we work together to achieve the global health security. One has required a shift of paradigm that veterinarians, medics, environmentalists, and other partners must come together to better prepare and better detect and respond to health crises. This is what we from Senegal, we understood since 2015, when the Prime Minister of Senegal himself decided to create a high committee of global health security in Senegal based on the One Health approach. And as you may know, it was a shift of paradigm because there was no formal framework in the country which organized medics, veterinarians, environment, and other partners to work together to be able to give better health to people and to animals and also plants. That's why the government in the high level decide to create this high council, encouraged in the Prime Minister officer, which oversees all other sectors who was supposed to collaborate to implement the One Health approach in Senegal. That we call the multi-sectoral collaboration. This High Council is derived to committees, but also working groups. If I can say the antimicrobial resistance working group, the zoonotic disease working group, and other working groups which work to elaborate strategic document. The first one was the National Health Security Strategic Document, and also the Antimicrobial Resistance Surveillance Strategic Plan, but also the Zoonotic Disease Surveillance Strategic Plan. For the Zoonotic Disease Surveillance Strategic Plan, we arrived to have a list of priority zoonoses selected by all sectors under the umbrella of the High Council. Those 5 zoonotic diseases are currently in surveillance within the countries. In terms of multi-sectoral collaboration, the High Council organized the sectors and create the National Management Crisis Committees, which is now the committee which is managing the COVID-19 response in Senegal. And in these committees, we have all sectors, animal health sectors, human health, environment, the sociological sectors, and all partners. Up to now, these committees who handle the COVID-19 response in Senegal. Always in this deliberation of the High Council, we undertake in Senegal the GEE, the Joint External Evaluation, and in 2016. And it was under the umbrella of the High Council. During the GEE, all sectors was also involved. Even we did the OIE gap analysis in the same time when we did the GEE. If you see, Senegal was one of the 2 first African country which was able to test COVID-19. It is because we prepare ourselves before the COVID-19 crisis came. If you see the reports we had undertake during the first month of the COVID-19, it was because we was very prepared to be able to face health crisis. That's why Senegal was named as the 2nd country in the world with a good response during the first month of COVID-19. I'm concluding here to say that we need really preparation. Preparation is very key to be able to implement the One Health approach properly, to be able to give good health for people, animals, and plants. Thank you for listening.
Thank you very much indeed. That was absolutely fascinating. Thank you to all the panelists. I believe we've had 9 really interesting in-depth discussions, which were all very inspiring. So I'd like to start with a question to Mrs. Ankana Lakakul from Thailand. Please, could you share the experience of mobilization of health workers and the investment in them?
Actually, in my presentation, I think the community health worker in Thailand, we called it the village health volunteer or VHV. We have around 1.3 million across the country. I think back in 40 years ago, we start with asking the people in the community whether they want to be a village health volunteer, and we train them according to the primary health care policy. We recruit them from the village and train for 2 weeks. And then we, I think in the first decade or first few decades, they don't have any payment, but we just start giving them about $20 per month. I think in the last 5 or 6 years. And after that, I think they work closely with the health center to work with the community.
Engaging the private sector in the emergency response has been mentioned. The approach appears to be ad hoc and demand-driven. Are there any frameworks or systematic approaches to engaging with the private sector in a scenario as we've experienced recently?
What I'll say is that within our public sector, I mean, be it education, health, agri, there are units and departments tasked with private sector engagement, which they do on a continuous basis. And even within legally, there's a legal framework, the PP, the Public-Private Partnership Law, that sort of defines how public sector engages with the private sector. But then given the COVID-19, I mean, there was a more concerted effort because the response was a whole sector response. So then the private sector was brought in a lot more. So I wouldn't say it's ad hoc. I would say rather it's an enhanced existing engagement. Yes, to let the private sector also contribute with their capacity that is within them, both for service delivery, both for manufacturing of PPEs and other things. Over.
How do health systems intersect with the One Health approach in practical terms? We have spoken about how siloed these programs are in terms of their implementation. How do we harmonize them? Who is in the lead? And how far does the health system's strengthening mandate extend?
Thank you. It's what I already explained in my talk when I talk about the High Council of Global Health Security based on One Health approach created in Senegal, which is a structure headed by the high level of the government, and where we have the all health sectors, animal health, human health sectors included inside. With this High Council, in practice, is groups where we have medics, veterinarians, environmental biologists, and all other partners working together. For example, for field epidemiology training, FETP, we train together with veterinarians, medics, and also people coming for the myth of environment together, strengthen their capacities to be able to implement disease surveillance on the ground. And also from the ground, we have some groups, community health workers we train. We have animal health community health community workers. We have human health community workers. We train together. Even we have environmental community workers. We train together. And those people are within the flow chart to collect information on the ground and send it to the central level. We experience using the technology of communication like internet, also WhatsApp group, and also using the cell phone. They collect the information, they send it to the local focal point of the health sectors or the environment sector, and those people share it with their head in the central level. So, for example, the kind of mechanism we're using to put all these people together from the ground, working together, and also link it to the central level where we have the head also working together in a multi-sectoral collaboration way. Thank you. I want just to to give a comment on the question you raised previously, so that somebody asked, who should the lead in the implementation of the One Health approach? Who should the lead between the human health sectors, animal health, and environmental sectors? I should say that we have to consider that in the One Health approach, no sector should be below another sector. All sectors are in the same level of dignity. It's about collaborating, working together, thinking together to be able to act locally and properly on the ground. The one who should oversee, from our example, the head of the government. Sometimes it's the prime minister, in some countries it is the president himself. And I think that in that way, everybody will be confident and at ease to work together and give his best for the success of the One Health approach. Thank you. Over to you.
What financial mechanisms were used to be able to reimburse the local governments and financial institutions for the PPE, etc.? Was it a reallocation from other areas, or were there emergency funds in place?
Thank you. Very good question. In Finland, we have a national emergency supply agency with its own annual funding, and that was one part of the national procurement of PPEs, and that was one part of it. And of course, the funding for regional operators, healthcare providers, was from the state budget, and of course it required state loan and maybe the effects will be shown whether it requires real allocation or some adjustments in the budget, but these were the main mechanisms. And I think that the kind of the global collaboration and the role of WHO in preparedness, what will be required to purchase, for example, medical care stuff or PPEs or medicines. I think it's very important that we have this kind of information, global information, also in terms of being prepared and making good purchases and in these kind of pandemics. Thank you.
Please, could you share how India is managing adverse events following immunization, especially from the pharmacovigilance aspect?
With regards to vaccine safety, during the pre-pandemic era, our focus was on the universal immunization program, the pediatric vaccines. In India, almost 85% of the vaccines are given through the government's UIP program. So our AFI surveillance program was focused on the pediatric population. But with this new age group, the adult age group, we had to work on modifying the AFI surveillance program, starting from expanding the reporting network and also modifying the formats for adult AEFIs, also keeping in mind that the COVID-19 pandemic was also occurring. So some of the adverse events would actually be COVID-19 cases. And also the post-mortem verbal autopsy formats had to be redesigned. We did not have a reporting from the field. The vaccinators were not able to report. They had to report first to the district immunization officer, and then further on, he would report the serious and severe cases. We had decentralized the reporting system. Vaccinators were able to report AEFIs directly onto the software. So real-time data was actually flowing in each day. With regard to the signal detection process, signal management process, we are still a developing country in that regard. So we quickly had to work with the pharmacovigilance stakeholders, those who are managing the adverse drug reactions. We started working with them in the last months of last year, and together working with them, we have now a signal management system. But there are some nuances. So when we get these cases, we don't get the diagnosis. We don't have a good diagnosis. So the first step is that we do a rapid analysis here of the case records at the national level, and we have a diagnosis in place, and then the signal detection processes start, which is slightly different from what the developed nations have. They already have diagnosis in place. It's all in the electronic version. So signal detection makes it very easy in those settings. But in our settings, it takes a slightly more time, but we are learning and we are speeding up the process.
Thank you so much. I'd like to thank everybody once more. It was a fascinating session. I really liked the organisation of the session around the different building blocks and the way that we heard about successes and challenges in each domain of the health system. And thank you also for the contribution on multi-sectoral action. I found it particularly useful to see community engagement mentioned there. And also, as someone who works in the AMR space, I was delighted to hear about One Health and those intersections between animal, environmental and human health, which are so critical, as we all know. So once again, many thanks, and I'm going to pass back to Professor Garrett Brown now. Thank you.
Thank you. I only have 3 points before we close this out, or before we have it closed out by Estella Chungun from the WHO. First, thank you all very much for your participation and for your interest. And I'm sorry we couldn't get to all your questions, but that's my second point. We will keep all these questions and we will be reflecting upon them moving forward. They will be informing us on the type of evidence to collect, the type of opportunities available out there, and types of lessons learned. So we will be using these questions even though we haven't gotten to them today. Lastly, you will be invited in a few weeks' time to join the network, the Health Systems for Health Security Network, and we'll give you some other information as well. But do expect an email from us. Part of this workshop was to try to get a community of interested people together to help take this platform forward and to help us think about this platform more. So to close us out today, I am very happy to present to you Dr. Stella Chungun. She's the Director of Health Security Preparedness at the WHO and a Leeds alumnus, which is something I learned recently, and I'm very happy to hear it.
Thank you so much, Professor Garrett. Professor Simon Butenek, Vice Chancellor of the University of Leeds, representatives and experts from member states and partner agencies, colleagues in WHO, country offices, regional offices and headquarters, professors, doctors, and experts from the University of Leeds and others, students from the universities all around the world. Good morning, good afternoon, good evening to you all. And thank you very much for participating in this workshop today. I am particularly pleased to give closing remarks at this event co-organized by my alma mater, where I had completed my Master's of Public Health over 25 years ago. The University of Leeds set a strong foundation for my career in public health and emergency preparedness and response, for which I am grateful. Today's workshop has been an excellent opportunity to recall and discuss how strong health system capacities is critical for health security. The COVID-19 pandemic has been a brutal reminder of how strong health systems capacities are critical for the effective management of health emergencies. It has hit many countries hard around the world across all income levels. Many have struggled to respond to the pandemic while delivering essential health services. COVID has also provided critical lessons for all of us. These include sustaining advances for preparedness made during the pandemic, integrating innovative approaches, and investing more in preparedness capacities to ensure robust health security. Most importantly, it has also provided lessons about building back better and breaking the panic then forget cycle that has followed other severe emergencies. It is clear that the cost of preparedness is far less than the cost of response. The Global Preparedness Monitoring Board estimated that the cost of COVID-19 response so far is approximately $11 trillion, with a future loss of another 10 trillion in earnings. Emergency preparedness, to better meet the requirements described under the international health regulations, should build upon the health systems building block and associated functions that also contribute to achieving both health security and universal health coverage. This pandemic and other recent epidemics and emergencies, including Ebola, H5N1, MERS, have underscored the urgent need for more joined-up efforts between the health security and health systems agenda. This approach brings a complex set of conceptual and practical issues for countries and partners, and the discussions today have tried to untangle and address these. Today's workshop was an opportunity to introduce the Health Systems for Health Security framework, which WHO has been working on together with stakeholders. As described by Dr. Nirmal Kandel, this framework offers a common narrative and approach for countries keen to advance the strengthening of health systems that can meet the demands imposed by health emergencies, that are flexibly allocating resources to areas of greatest needs, and that are mitigating the disruptions that are created during health emergencies to essential health services. We envision that once published, this framework will provide a reference to support countries and partners, including the academic community, in bringing together resources, capacities, and organizational systems for this purpose. Today, we have also had the opportunity to hear from country experts from across WHO regions, as well as from partner agencies, on their experiences and lessons learned in strengthening health systems for health security before and during the COVID-19 pandemic. This includes the importance of building capacities in other sectors beyond health, including taking a multi-sectoral and One Health approach. Your contributions in this meeting have highlighted a deep interest in this topic and will pave the way for future work, including piloting the approach in countries. We also look forward to the future establishment of a network of experts from countries, academics, partner agencies, and international organizations, and to working with you and other stakeholders in moving forward from concept to actual implementation. In closing, I would like to echo the Assistant Director General of Preparedness Division, Dr. Jawad Makju, in expressing my appreciation and gratitude to our academic partners from the University of Leeds, and in particular, the leadership of Professor Garrett Brown, for your great support thus far in the research, the development, and the implementation of health systems for health security. On behalf of WHO, I would also like to thank all the speakers for sharing your valuable experiences. They have been insightful and informative. I would also like to thank all the organizers, technicians, staff, and students who spared no effort in organizing this virtual event successfully. I invite you all to join me in giving them a big round of applause from wherever you are. Finally, to all participants and panelists from countries, WHO partner agencies, and academia, I would like to express my gratitude, not forgetting Dr. Kandel and his team, who are leading this effort in my department. No country or institution can do this alone. Together, we can strengthen health systems and other sectors' preparedness capacities for a safer, secure, and more equitable world. I wish you all a good morning, good afternoon, and good evening.